हाँ जी। हाँ।
And we, in a notion that when pregnant woman came to me of 3 months pregnancy, carrying a child with frontal bossing, with severe anemia, growth retarded, 5 years boy, and that boy was suffering from thalassemia major. And they were not very well off, and with blood transfusion and all, things are not going well, but she conceived again, and she was asking me whether my next baby will be same or not. In 2010, I did my post-graduation in 1986 to 1989, and at that time I did prenatal diagnosis of chromosomal anomaly by trophoblast sampling. So you can understand that my inclination towards cell biology, and it might not be I was not knowing it is a fetal medicine at that time, but definitely there was a inclination about knowing about the fetus. With that, she was asking me whether my baby will be okay or not. It is a question in 2010 when I was doing Korean biopsy and amniocentesis, and with the Genetic Lab Association in Bangalore and Chennai, I did a Korean biopsy, and fetus was found to be thalassemia minor carrier. But on that day, when I felt that this is very important thing that the person inside the womb should also get a care and be healthy. With that, on the same day, I got a call from a pharma company, and they asked me to do some meeting and all. Then we decided that why not we start a date to the unborn, that is Fetus Day, and it was on 29th October we discussed, and on 31st October we did a meeting, first meeting with Jabalpur Obstetric Gynec Society. Since then, we dedicated this 31st October to the fetus, to the unborn, and gradually we got accepted by our national federation, that is FOXY, in 2016 or 17. And if you now do this search, by God's grace, Jabalpur comes. So wherever you are, I was not accepting this fact this is happening. I called one of my friend in Stockholm, and I asked her, see whether it is same there or not. She told me she is also looking the same. So these are the continuous method, continuous effort with making an effort to make a fetus as a patient. And now fetal medicine is a separate subject, separate entity, and with that, I welcome you all to the FetusCon 2025. Because 31st October is not a Sunday usually, so we do the nearest Sunday as FetusCon, but this year एक marriage थी हमारे बहुत important society member के बच्चे की, so we shifted to the 9th. I welcome you all. The subject is very simple, that whether exploring fetal medicine as a carrier, exploring fetal medicine as a career to the newly passed out gynecologist. I'm very happy and I feel very happy that now this medicine, this branch of medicine with the unborn has grown up like anything, although I am not doing too much of fetal medicine, but basically I am a red flagger. And with fetal medicine, dedicated Dr. Mani, Dr. Avantika, Dr. Shweta might be reaching very soon. These are the people, if we refer them at a proper time, they can do a lot of interventions now. And with these interventions, we can, where we were not able to find any alive baby after delivery, these doctors, these specialists, they help us to get that output in a better way. So I started calling one fetal medicine dedicated person, 1 or 2 every year, so that my fellow gynecologist and me get conversant with what is happening in fetal medicine world. And we have with Dr. Mani, Dr. Avantika, Dr. Shweta with us, they will show us how advanced it is now. And जिसको हम लोग सोचते थे कि ये हो नहीं सकता, things are happening. For a new gynecologist, जब मैं भी pass out हुआ था, बहुत सारे बच्चे pass out होते हैं कि should we take fetal medicine as a sole specialty to practice? Yes, it is very important and you can survive with this fetal medicine in private practice also. See, any practice, if you are in an institution, very good in metro cities and all, but in smaller cities like me, if I practice fetal medicine exclusively, things are little bit difficult. But if you are in an institution, no limits. The fetal medicine bridges obstetrics, genetics and imaging. मैं सबसे important बात जो बोलना चाहता हूँ, that is fetal medicine is not intervention and ultrasound. You have to have a thorough knowledge of cell biology and genetics. Otherwise, it is incomplete. सबसे बड़ी problem ये है, in our curriculum, in our medical school, medical college, हमको clinical genetics नहीं पढ़ाई जाती. And if clinical genetics is not applied and not been taught, who has become a gynecologist or a radiologist, and you are going to give a care to an unborn, which is full of genetics from the parents, full of genetic disorders might happen in the unborn which you cannot see. Because pediatricians, they bring the child with phenotype. The baby is not thriving well, or there is a convulsion, or there is mental retardation. But in fetus, how there is very difficult to know the phenotype, because sometimes ultrasound phenotypes are normal. But husband and wife are carrying thalassemia carrier, sickle cell carrier. In my next talk in the afternoon, I will put 2 or 3 cases where an obstetrician or gynecologist, even if they do IVF practice or fertility practice, you cannot do away with genetics, because the person or the lady gets a pregnancy will come back to you. And till delivery, she will be with you, and if there is not a good output, then you will feel bad. So this is very important, that you need to know about the genetics. I run a lot of courses on genetics also. I have next generation sequencing lab with me. We do exome sequencing, NIPT in-house. So this is the way I developed this, and this is monetarily viable. This is very important. Why? Because you have to earn your livelihood. तो आप कैसे इसको handle करेंगे? Because things are difficult. This presentation introduces capacity to new OBGY postgraduates focusing on training skills and opportunities. We have fetal medicine consultants with us. How they have acquired this knowledge, we will take, if you want to talk to them, they are with us. Expanding field of diagnostic and interventions focus on fetus as a patient, integrates ultrasonography, genetics and perinatology, offers intellectually stimulating and evolving career path. You have to be very careful about what you are going to do. सिर्फ अल्ट्रासाउंड करना, टारगेट स्कैन करना, एक एंटी स्कैन कर देना, it is not enough. You have to undergo inside why. And after why, can I prevent it? So my sole motto is Fetus Day is, if fetus is healthy, then nation is healthy, because you will have good neonate. So scope in modern obstetrics, early pregnancy assessment, anomaly detection, fetal diagnosis, genetic counseling and prenatal testing, fetal therapy and perinatal management. One of the very important aspect of fetal medicine or any test to the pregnant lady for her baby, because every lady has a fear that mera bachcha to theek rahega na, my baby will be all right. At the end of the day, she will ask the obstetrician, because she comes back to the obstetrician. My baby will be all right? Now you put tests. Which test? You should know the test. Before giving the test on her paper, she does the test, follows your instruction, comes back with the result. You cannot say that the result take you go to some geneticist or somebody else. Is it better that you should know what is the interpretation of the test? Then only she will be with you. For fetal therapy and all people with high degree of fetal medicine knowledge, they are there, they will have talk to them, get an idea whether it is treatable or not. With the geneticist, talk to them, you will give a better result and better output. Very difficult thing in my practice. You need a high resolution ultrasound. Whenever you go for a high resolution ultrasound, जिसके घर में बहुत ज़्यादा सपोर्ट नहीं है, एक 30-35 लाख की मशीन खरीदना, अभी आप जब बैंक में जाते हो, what happened with me? You don't get a loan. At that time, I started with a simple linear scanner of Aloka in 1991, which was donated by me by my teacher. I still, Dr. Shashi Khare को मैं जिंदगी भर याद रखूँगा. But I learned this sitting by the side of a radiologist who was doing, because I was not allowed to touch the probe, but I have learned that. And by God's grace, I got that machine. For 5 years, I did intervention with that also. And then I purchased another machine, then earned money, then another machine, then earned money, then another machine. Now I have, the machine is costing, जो मैं 3 साल पहले खरीदा, that is, if you want to have a good ultrasound output, good machine. Then it goes to 1 crore, 2 crore. Putting money into an ultrasound machine in this amount, you have to have a very viable practice. Then only, for doctors, return of investment never comes. We are जुनूनी people. हम पैसा लगा देते हैं to get a good result, good service. But it gives immense satisfaction if you have a good ultrasound machine. Knowledge of fetal anatomy and pathophysiology. When I teach people, मुझे embryology नहीं पढ़ना, पढ़ना है. You have to read if you want to be a fetal medicine specialist. Because try to catch it as early as possible, embryonic defects with ultrasound. Machines are so good, you can see the sonoembryology now. आपको फर्स्ट ईयर का एनाटमी और एम्ब्रियोलॉजी री इन्वेंट करना पड़ेगा. Understand the genetics and screening tests. What is screening test? What is diagnostic tests? Intervention technique. If you cannot do it, take help. But don't avoid. तो आपको यूज करने के लिए you have to read it. आपको interpret करना पड़ेगा. What are the complications? And definitely audit yourself कि आप ठीक कर रहे हो. Core components are very simple. That is fetal imaging. आपके पास कैसी मशीन है. If you go for 3D, 4D, 2D resolution improves, and 2D resolution if improves, your diagnosis will be better. Your images will be better. Fetal diagnostics करते 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 ये हो गया कि should I have post-invasive diagnostic methods also with us? I am doing DNA PCR since 1996. 1996. Thalassemia का diagnosis. But the problem is I am alone, no help. So gradually it is such a yes or no test that with my report, the lady will keep the pregnancy or terminate it. So I took a help from a geneticist, took a help from a lab, but I had that idea that I can do. So I started with cancer cervix and all PCR and TB PCR where there is no life and death risk. But with this technique, I learned PCR technology, I learned DNA technology, and with this, today I have sequencing machine with me. So it is a long journey. You can also do this. For genetic counseling, you need a good knowledge. Fetal therapy and in utero procedure, Dr. Manikandan is with me. Avantika might be doing in AIMS. Send them for fetal transfusion. Send them for TTTS problems. The flowchart pathway to fetal medicine, you do MS, DNB, OBGY or MD radiology. You can do a fellowship in fetal medicine. You can get accredited with Fetal Medicine Foundation or ISWAG. As a gynecologist, myself, I stick to ISWAG because ISWAG stands for International Society of Ultrasound for Obstetrics and Gynecology. That means it is meant for you. Follow it, your practice improves. When you stick to their guidelines, your practice improves. I do that. So, Dr. Mani is with us. He can also guide us how to the youngsters. There are a lot of centers which are available, or you can go abroad also. And Fetal Medicine Foundation, such a generous foundations that they give you free education, free website, free access, lot of things. If you go to perinatology.com, you get lot of free access. Read it. Your practice will improve. We have Society of Fetal Medicine here. Lot of work is being done. And so we can get e-learning. Normally, I take e-certificates from ISWAG. यदि मुझे ब्रेन का करना है, then I do a course. कितना पैसा लगता है? 4,000 रुपये, 5,000 रुपये. पर आपको वो जो सर्टिफिकेशन मिलता है, सर्टिफिकेट इज सेपरेट, डोंट, हम शो करने के लिए नहीं है, पर जो एक थॉट प्रोवोकेशन होता है, दैट इज वेरी इंपॉर्टेंट. सो यू नीड हाई रेजोल्यूशन. इफ यू वांट टू डू फीटल इको, इट डिपेंड्स ऑन यू. We do non-invasive prenatal testing, and fetal MRI and AI-based things are now coming very. So integration with genetics is very important. Clinical practice setup, jamana is very difficult, but एक बार यदि आप उसको establish करते हैं, things becomes very good. So you need a team, obstetrician, geneticist, sonologist, and counselor. So career opportunities, academic institution में आप जा सकते हो, but it will be a fixed salary. But you get a satisfaction. Corporate hospital, again, lot of politics, lot of things happens. तो आपको वहाँ stay करना, रहना, if you are good, people will keep you. Private fetal medicine units, very little bit challenging, because solely doing fetal medicine, you have to be very good. Research and genetics laboratory, we do that. and with national and international collaboration. So these are all challenges and rewards you get by doing. These are research opportunities with lot of, it is up to your inclination how you do it. And very important, जो लड़कियां बोलती हैं वर्क लाइफ बैलेंस चाहिए, तो वर्क लाइफ बैलेंस इज देयर. आपको 9 से 5 काम करना है, यू कैन कम बैक, बट आई कैन नॉट डू दैट बिकॉज आई नीड मोर टू गेट मोर, टू एडवांस मोर. बट definitely it is a very nice opportunity and nice your career path. So in conclusion, the fetal medicine is a future preventive obstetrics. For new gynecologist offers balance, depth and growth from obstetrics to precision fetal care. And I give special thanks to, because lot of things are being done by my machine people, that is Samsung, and thanks a lot for your patient listening. Rakhi, aaja. To the time, that is, I had been for 9:20 to 9:50, and it is 9:45. I kept this window, the people will come, and with us we have our local branch of Federation of Obstetric Gynec Society, that is Jabalpur Obstetrics and Gynec Society. I am very, very thankful to them that I am very well connected, taken care, integrated by our society. Rather, in 1993-94, I was the instrumental to increase this number of the society members. And till today, they are very younger to me, but I have been taken as their elder brother, and they support me, and I also with this Jabalpur Obstetric Gynec Society. Our intention is to spread the knowledge about the fetal medicine, fetal health care, as a patient, to get a good outcome. How to prevent genetic disorder, how to prevent problem in the fetus as early as possible, catch it early. And in my afternoon talk, I will show you catch them before. So things has gone gradually, but you have to have that inclination of having, it is not difficult, but difficult career path, because we have not been taught about genetics in our OBGY. We have been taught about little bit of ultrasound, but keval ultrasound is not enough. You have to have the knowledge of how embryology happens, how genetics happen. I request Dr. Komal, she is a secretary, Dr. Rakhi Bajpayee is our president, and she will now conduct the meeting, and we will try to stick our, this is the, so mera 9:50 tak ka tha.
Good morning all. I, Dr. Komal Jain, Secretary of Jabalpur Obs and Gynec Society, welcome all of you in this FetusCon, 16th FetusCon, which is the annual medical conference regarding fetal medicine. Before forwarding the session, I welcome all the chairpersons of the first session, Dr. Sneh Prabha Chaubhe ma'am, Dr. Sulekha Devani ma'am, and Dr. Poonam Bajaj ma'am from Katni. I would like to call Dr. Rakhi Bajpayee ma'am, who is the president of Jabalpur Obs and Gynec Society, to please say a few words regarding this conference. Ma'am, please. Thank you.
So good morning and warm welcome to all of you. Respected Dr. Manikandan Krishnan sir, renowned fetal medicine expert from Pondicherry, Dr. Shweta Bhandari, Madam from Indore, Dr. Avantika Gupta from Bhopal, Dr. Professor Geeta Goin, Madam Head of the Department, Obstetric and Gynec Department, NSCB Medical College, Jabalpur. She has not yet arrived. All the faculty members, chairpersons, our radiologist colleagues, pediatrician colleagues, fetal medicine experts, and everyone who is present over here. Warm welcome to this lovely gulabi winter morning. थोड़ी थोड़ी ठंड चालू हो गई है. Hope you are cozy and ready to dive into the insightful sessions on fetal medicine. It's going to be a valuable opportunity to learn from expert. Fetal medicine is a specialized field focusing on the health and well-being of unborn baby. It involves diagnosing and treating conditions affecting the fetus during the pregnancy. The team FetusCon have put together an insightful program, and you are going to gain a lot from it. Regarding FetusCon, I would like to say that FetusCon has truly come a long way. It was 16 years ago, on 31st of October 2010, when Dr.D'Pankar Banerji sir pioneered the celebration of Fetus Day by the name of FetusCon, not just in Jabalpur, but across India. His vision and initiative has inspired many. It's amazing to see its impact that FetusCon is garnering national and international recognition today. Happy sweet 16th birthday to FetusCon 25. मैं सभी को बोलूँगी कि एक बार FetusCon के लिए तालियां बजा दें. Here's too many more years of growth, success, and making a difference in fetal medicine. Kudos to Dr. D'Pankar Banerji sir and the entire team, including JOCS member, for their tireless efforts and dedication. Cheers to continued excellence and innovation. And one very important notice, FOGSI is inviting application for the Faculty Pool 2026, led by Dr. Bhaskar Pal sir. If you are interested in becoming part of this initiative and willing to travel, please fill out the proforma shared in the group and submit it to me or Dr. Komaljan, so that let's start this super informative CME session on fetal medicine, FetusCon 2025. Over to Dr. Komaljan. Thank you. Thank you so much.
Dr. D'Pankar towards FetusCon, and I will not be wasting time. We have great speakers.
Chairperson, sir. Yes, ma'am, you are requested to please call the second speaker. Thank you.
Yes. I invite Dr. Manikandan Krishnan to give his talk on aneuploidy screening from double marker to NIPT. What to recommend? We know there is a great confusion exists when to do NIPT, when to do biochemical screening, and what are the implications. So, sir, you are welcome to the Jabalpur and our society, and we are very eager to hear you and clear our doubts.
Let me thank you for coming on a Sunday morning. Very nice weather to sleep in, but you had the academic urge to be here, and I'm sure it will not be wasted. A few months ago, when D'Pankar sir called me and told, he sent a text message, I've heard from you, I've heard about you, Bijoy told, and then I checked with Pankaj Kundra, who is my friend. Then I said, yes sir, I'm available on that day, I can come. I didn't know that FetusCon was such a big thing. And the journey that you have taken is very inspirational. I want to just ditto it, and that should be the right path to follow. I also practice in a small time town. Pondicherry is actually about 20% smaller in population when compared to Jabalpur. So when I talk about the demographics, when it comes to all these things, it would apply to Jabalpur also. It came, no? Been through that when we are gynecologists, and then the lab comes and bombards us with a lot of tests, we tend to get overwhelmed. But before that, this is my team, they are my fellows. I have a program, it's not less than 1 year. For radiologists, I offer 1 year because most of them want to learn a bit of fetal imaging. But for gynecologists, there should be a change in the DNA. So that takes about 2 years of intensive training. I have with me now 2 people, that is Akanksha and that is Shivani from Madhya Pradesh. So they used to keep telling Madhya Pradesh is the heart of the nature. And I said yesterday I sent back the picture. It is the heart of nature. Right. So I will talk about something about the background. I will talk about screening concepts, then screening tests. We will build up as the evolution occurred. Then I will tell you what is the screening protocol that I follow at the fetal clinic. And then we will discuss a bit of special situations, then we will summarize. Now, the screening program's background is the urge to prenatally diagnose intellectual disability. And when we say intellectual disability, it could be genetic or it could be environmental, say perinatal hypoxia or other things. But the genetic intellectual disability, most common is Down syndrome, and that belongs to a group called chromosomal abnormalities and euploidy. The second most, however, falls way back. That's a single gene disorder called Fragile X. There is no point in running behind Fragile X in the general population. So we run behind Down syndrome. When we say aneuploidy screening, we are primarily running behind Down syndrome. And why is that? Because all women are at risk. That means they have a chance. About 70% of women who give birth to Down syndrome babies come under the young age group. And Down syndrome is an asymptomatic presentation and hence screening. If it's symptomatic, you don't need to do screening, isn't it? It's asymptomatic. 50 to 60% of Down syndrome fetuses absolutely normal on ultrasound. There won't be any change, any symptom, any sign. And Down syndrome fetuses, unlike let's say Patau syndrome, Edwards syndrome, they don't die inside. If you see some Down syndrome fetus at 12 weeks, maybe 20 to 30% would die. So they are going to be born and you have to manage them at birth and after birth, proving a significant economic and more importantly emotional burden to the family. So let's understand the concept of a priori risk. A priori risk means what is the chance that this lady who walks to my clinic, I haven't seen her, I haven't done any test, has a Down syndrome fetus. What is her chance? So if you take the group 1, the majority of our patients fall in the group 1. The median age is around 24 weeks. Let's say there are 50,000 women such age in Jabalpur. You would have about 35 Down syndrome amongst that group. So therefore, the probability of carrying a Down syndrome fetus, just because she is a lady of 24 years, is 1 out of 1,400. So she has a chance. Let's take the little lesser group, lesser numbered group, that is about 35 years, the executives, the professionals who marry after planning their career and then they come to us. There will be about 5,000 of them every year. And amongst them, 15 women would carry Down syndrome. So 35 out of 50,000, but now in this group, the highly accomplished group, 15 out of the 5,000 group. So that means the probability of an executive walking into my room with a pregnancy at 35 years is about 1 in 350. So my antennas are up more. And then there is this third group, which is the IVF group. They don't get conceived due to many factors, and then they finally, a lot of delay, end up in IVF. Many of them would want to use their own gametes, 42 to 45 years. Very rarely it may be natural conception. This group is a small group, maybe 125. And in this group, 5 of them would be a Down syndrome fetus, giving a probability of 1 in 25. All right. Now, what does this say? I said, if the mother's age is more, the probability increases, and as the pregnancy progresses, 30 of them will die. What does this say? This says that the incidence and prevalence of Down syndrome in the pregnancy increases with maternal age. So, if the maternal age increases, there is an increase in the chance of Down syndrome. We all know that. There is a sharp inflection around 32 to 33 weeks according to Indian data. Now, we also saw that about 30% of Down syndrome fetuses will actually die before birth. Therefore, if the pregnancy is ongoing, the chances that it is Down syndrome is actually going to be lesser and lesser, and therefore, at birth, many of them who are born would not be Down syndrome also. So, this is a slight concept that we should understand to calculate what is called as a priori risk. All right. Now, let's move on to screening concept. Now, there is a general population, it's a mixed population, and in this mixed population, when I apply a screening test, my goal of applying that screening test is to segregate, to separate a small portion of this general population into a group called high-risk group. Now, in the general population, the disease-carrying women, the fetuses, abnormal fetuses were well spread out. You can't focus on them. But in this small group, about 9 out of 10 Down syndrome fetuses are put inside that. But you would also see that a lot of normal women are also come into that group. It's like you have a stack of rice, there's a small insect running, you go and catch like that. You would have caught the insect all right, but you also would have caught a lot of normal rice, isn't it? Then we have to sort it out. So, a screen positive means it would identify that you are at high risk. Inside this high risk, almost all, but not all, of the true disease babies, the true disease fetuses with Down syndrome will be caught, but you would also have a lot of normal in the high risk. This is very important to remember. In the high risk group, a lot of normal fetuses will be there. Now, when the test says you are screen negative, that means the chance that you will find a Down syndrome in that group is very, very, very low, but not nil. So, you need to tell that to the mother. Your very low chance, but occasionally it can happen. So, that is also very important. All of us, gynecologists, radiologists, fetal medicine people should talk the same language so that patients don't get undue expectation, and when eventually when a Down syndrome fetus is born, then they don't come back with all the weapons against us. Now, if you see in the screen negative group, 1 out of 10 Down syndrome fetus would be missed. All right. So, that is that. So, when I say 9 out of 10 fetuses are picked up, that means the detection rate for that test is 90%. Let me just go back to that. Yeah. So, this group only we are going to be concerned with different tests. It identifies 5% of the population as high risk. That means when you apply the test to 100 women, all the 100 women that comes to your clinic, you say undergo the test. The test will capture 5 of them and say they are high risk. That 5 high risk women, you do the amniocentesis, then the next 5. So, if you do 100 such women, of all the Down syndrome, you would have picked up 9 out of 10. That is 90% of Down syndrome you would have picked up by this strategy. That means this test has a detection rate of 90%. It won't pick up all the Down syndrome. But it also has, and this is important, false positive rate of 5%. That means it would falsely identify 5% of the women from the normal set also. So, we have a detection rate, we have a false positive rate. From time immemorial, the false positive has been set as 5% or less. You should not exceed that. Within that, how much ever you want to increase the detection rate, you keep on increasing. This was the concept. Okay, now let's look at the screening test. What did we learn about maternal age? When the maternal age increases, your chance of Down syndrome increases. So you can very well say, all those who are more than 35 years or more come for amniocentesis. That means you are applying a test called age-based screening. This test, how does it do? We need to know only detection rate and false positive rate. Suppose we keep the false positive rate at 5%. So only 5% I should test. That means 35 years. Beyond 35 years, in your whole population, 5% of the women will be 35 or more. So when you do age-based screening, the green is the false positive rate. For a false positive rate of 5%, then if you do only based on age, you would detect 35% only. Not enough in the current era, but once upon a time, that was the only criteria available. Then what happened? So this was way back in the 70s and early 80s. Then ultrasound came and people were looking for clues on the ultrasound. These were variations in anatomy, on ultrasound appearance of anatomy, that were commonly seen, more frequently seen in Down syndrome fetuses, but were also seen in normal fetuses. So they were called markers. They were called just markers. Now, if you see these variations, by themselves, they do not cause fetal handicap. So these markers, when they are born with the markers, they don't have any handicap. We won't call them as defects. So they were called as soft markers. So these soft markers, there are 9 of them today. One is mild bilateral ventriculomegaly. So each word is important. It should be mild, it should be bilateral, and it should be a ventriculomegaly between 10 and 12 mm. Then a thickened nuchal fold skin thickness. So in the mid-trimester, if the skin in the back of the neck is thicker than 6 mm or more, then that's considered a soft marker. Then they identified the nasal bone. It's either absent or hypoplasia, then your chance of Down syndrome increases. It's not that it won't be found in normal fetuses, but your chance increases. Then, where does the right subclavian artery originate? The right subclavian artery should be the first branch of the aortic arch, but if it comes as the last branch, that's an aberrant origin of the right subclavian artery. And then when you look into the heart itself, if you find calcific spots on the papillary muscle, which is called as the echogenic intracardiac focus, then that is also a soft marker. The bowel can appear very bright on the ultrasound screen. That's a soft marker. Again, if you have bilateral mild hydronephrosis, very minimal fluid collection in the renal pelvis, that's considered a soft marker. And if the long bones, humerus and femur, if they are slightly shorter, that means expected to observed is only 0.9. So what you expect, keep it as the denominator. What you observe, keep it as the numerator. Then the ratio should be 0.9 or slightly less. Then it is considered as a soft marker. So when people realize that some subtle clues are there, and if you join them all together, you would be able to increase the detection rate, then it became the genetic sonogram era, where instead of subjecting all women above 35 years, they were able to segregate more. With this strategy, you are able to achieve a detection rate for the same 5% false positive of 65% compared to the 35 before ultrasound came. But that was not good enough. Simultaneously, in the 80s, a lot of research was going on. Some were identified by luck, some by focused research, that between the gestational age 15 to 21, of many hormones and biochemical markers that were produced by the pregnancy, 4 of them stood out. They stood out because they had a near linear relationship with the gestational age. One was, the first one to be identified was alpha-fructoprotein. Next was identified HCG, then estriol, and finally dimeric inhibin A. So these had, in normal pregnancies, a linear relationship. So it either increases or decreases with gestation, and in the Down syndrome fetus, it was aberrant. It would be either more in the case of HCG and inhibin A, or less in the case of AFP and estriol. So there was a change, and scientists found out that if you detect that change, combined with the maternal age, you are able to find out more Down syndrome fetuses for the same number of amniocentesis. That means for the same number of false positive. So then comes the era of TST, which was then superseded by, triple was superseded by QST with the addition of dimeric inhibin A, and that was the quadruple screening test. But still the detection rate was only 70%. It was better than before, but it's only 70%. Then they understood that what you see on the ultrasound and what you measure in the blood do not correlate. Do not correlate, which means you can actually combine them. If you don't correlate, you can combine them and you get a much better test. So then came the era of genetic sonogram with quadruple screening test. This happens about 16 to 20 weeks. You do a full genetic sonogram, do the quadruple screening test. For those who are screen positive, you do the amniocentesis. Now you were able to detect about 80% of Down syndrome fetuses for a false positive rate of 5%. Now we are in the 90s. Now we have come into the 90s. This was the raging era. Many of us, when we read gynecology, Fernando Arias, this was the time. And then late in the 90s, by then the superstar of ultrasound, Kypros Nicolaides, came in with a hot news that the fetuses in the first trimester, so till now it was everything in the second trimester. In the first trimester, the fetuses show a very strong clue, that is for Down syndrome, which he called it as nuchal translucency. Now he said, when you perform this nuchal translucency in this manner, zoom it up, show it in the correct mid-sag plane such that you show the nasal tip, the palate and the diencephalon. If you focus like this, and then you see the nuchal membrane, measure the fluid between the back of the neck and the skin, then that is nuchal translucency, and it is increased in Down syndrome fetuses, but also in normal fetuses. So he proposed an algorithm by which, using the nuchal translucency, you can screen women in the first trimester. So that was the drastic change that happened from second trimester to first trimester, and with that he showed that you could detect about 75% of the Down syndrome fetuses. So the detection rate was not greater than the second trimester. But by now scientists are also aware that if you have hormones in the second trimester, you should have it in the first trimester also, isn't it? So they went about searching for a lot of hormones. All the second trimester hormones, no, they did not work well in the first trimester. But when they split from HCG to free beta HCG, then it showed a promise. It was different between normal and Down syndrome fetuses. And Pape also showed a difference between the normal and Down syndrome fetuses. So now they had a set of hormones in the first trimester, which they called as the double marker, but on its own, it didn't perform well. It was only like a triple screening test, like a genetic sonogram, about 65% detection rate. But we already knew what happened in the second trimester, so you combine them both. Because they don't correlate, you combine them both, and then the NT and biochemistry was the highlight. Very hot, 90% red hot. So it detected 90% of Down syndrome fetuses and became the global standard. But there was a problem. There was a problem because people wanted more, better, because you were doing 5% of women will undergo amniocentesis anyway. That was the standard. So how do we bring it down? So then Nicolaides came with more research, and he said, use any one or use all of additional ultrasound markers like the nasal bone, ductus venosus, and tricuspid regurgitation. But what found out was it was difficult to implement ductus venosus and tricuspid regurgitation en masse. In the whole population, if you want to train all the sonographers and radiologists, it's simply not possible in a baby that's moving too much. But nasal bone was promising because it used the same view as a NT, and then you have to focus on the nasal bone, that's all, present or not. So nasal bone, when you add nasal bone, the detection rate was about the same, it went to 92%, but what was significant was the screen positive rate. The screen positive rate dropped to 2%. So when you do a screening based on NT, NB and biochemistry consistently in all your women, if you screen 100 women, you have to put a needle for 2 women. And when you put a needle like that, you would detect 92% of Down syndrome fetuses. Many of them will turn out normal, but among the Down syndrome fetuses, you would catch almost all. But simultaneously with Nicolaides, who was working on the ultrasound, Dennis Lowe was working on the concept of cell-free fetal DNA. At that time, DNA was extracted from the mother, which showed some from the fetus also. So they worked on worked on the technology to amplify it, read it, sequence it, and to identify from which chromosome each bit is coming. So the cell-free DNA test became a reality after 2.5 decades of research, and now it is able to identify from the maternal blood how much contribution comes from chromosome 21. This is so accurate now that if you get a result, then the detection rate is 99%. But unfortunately, 4% of the cases we won't get a result. So the detection rate in the general population remains as 96%. But the most important thing is the false positive rate. It is not 5%, it is not 2%, it is not 1% also. It's 0.1%. So you can shave off all the false negatives, false positives when you use any other screening modality as a first step. We will keep this concept when identifying what is the screening protocol that we use. So these are the screening tests we have, and this is how it evolved. And the evolution was directed by detection rate with an urge to increase every time, and the false positive rate. That means the need to put a needle should keep coming down. So this is how it has evolved. Now, let's look at, with this background, let's look at the screening protocol at the fetal clinic, 5 more minutes. So what we do is all pregnant women are given the opportunity to undergo Down syndrome screening and pre-eclampsia screening. As a obstetrician, I feel pre-eclampsia screening is far more important than Down syndrome screening. Now, many of them will accept, but some of them will opt out due to many reasons. If they opt out, we document it in the case record and we say, okay, come back for the ultrasound screening. When they accept the screening, then the first step is a detailed fetal ultrasound. This is how it goes. The first step is a detailed fetal ultrasound. And during this evaluation, about 1% of them would be found to have a fetal defect in the first trimester itself. About 1% of them will have a nuchal translucency of more than 3.5 mm. It's a cutoff. When you have these two situations, then they don't go for screening. They go for direct testing, either CVS or amniocentesis on the case basis. In about less than about 0.5% of my population, they will be age more than 45 years, and in this group also the combined screening test won't work. For them, I offer directly NIPT as the screening test. Sometimes they may think they have come for the first trimester, but the crown rump length is more than 84 millimeters. That means they are not in the first trimester, and in them, I say you have to come back at 16 weeks for QST. That is the next step for you, unless you are aged more than 45. So now with this situation, if everything is negative, all those bypasses are not there, then they undergo the step 2, which is called combined first trimester screening. So we take the maternal age, risk factors for pre-eclampsia, blood pressure, uterine artery PI in ultrasound, and in the ultrasound we take the NT, NB, and it's a teaching institution, so we also include DV and TR. Not required if you are practicing here as a separate private practitioner. Then we take the blood, we do the free beta HCG, PAPE, this component is for Down syndrome screening. We also do the PLGF in the first trimester. The additional cost is very minimal compared to the benefit that you get by preventing preeclampsia. So as obstetricians, preeclampsia should be there on top of your mind when you are offering screening. Once the combined screening test is done, then you will have two results, trisomy 21, what is the screening result, and preeclampsia. Trisomy 18, trisomy 13, don't worry about it. Don't worry about it. Anyway, they will show some defect or they will die in utero or immediately after birth. You don't have to worry about them. Now, when the final risk, after the screening, if the final value comes as less than 1 in 250, that means 1 in 500, 1 in 1000, 1 in 2000, that's screen negative. Reassure them, but call them back for the target scan at 22 weeks. If the final risk is 1 in 250 or more, 1 in 100, 1 in 50, then they are called screen positive, and then comes the screen positive protocol. The third step when you are screen positive is you have to do a step of diagnosis or exclusion, and this actually depends upon how high the final risk was. If it's okay, medium high, let's say 1 in 50, 1 in 100, 1 in 150, that means less than anything less than 1 in just 20, then many of them would be offered NIPT. Not all of them, many of them would be offered NIPT, but some of them would be offered direct testing. When the final risk is very high, more than 1 in 20, always direct testing. Now when you do NIPT, again NIPT is a screening test. If it comes as high risk, high probability of Down syndrome, you have to offer invasive testing to confirm. If it comes as low risk, or if your direct test comes as negative, then they go back to their routine care. Now let's quickly see, in another 2 minutes we'll wind up, special situations. This is a 36-year-old teacher conceived for the third time. First baby was normal, but in her second baby, the baby was born with a pure trisomy 21. This lady, theoretically, she can be given screening, but no person with the Down syndrome at home would accept again a test that can miss 1 out of 10 Down syndrome. She is at risk. She is at increased risk than before. So in her case, the best option would be NIPT or CVS. In my practice, I don't offer them combined screening. Now next is a 24-year-old mother. In South, they marry their maternal uncle also. So she married that. And her first pregnancy, the baby died due to spinal muscular atrophy, which we know is an autosomal recessive disease, and both parents were carriers. She has come now. In her case, again, I don't do screening. I plan a CVS at 12 weeks, and I try to see the SMN gene status in the fetus. Along with that, I will do a QF-PCR for Down syndrome. So Down syndrome direct testing would be done. So again, no screening in this situation. Now, the third situation is a 23-year-old software engineer. She had a screening done for Down syndrome. She came for high risk screen positive 1 in 130. So in this case, I do a ultrasound. If the baby looks absolutely clean, then in her case, NIPT is a good option. Then the fourth case, again another common situation, 23-year-old staff nurse, NT is 4 mm, but rest of the baby is clean. But here the NT is more than 3.5 mm, so we don't give NIPT, we don't give combined screening test, we give only a direct test. She has come before 14 weeks, we do a CVS. All right, so to summarize, firstly have a screening policy like that. Don't act selectively. Some women will come, okay, I will screen her. Some, no need to, that should not happen. Have an accepted screening protocol based on the literature. We have an information leaflet. We also have a video pre-test counseling. I sit and prepare a 10-minute video which they have to undergo. And we have in-house, like Dr. Banerji told, we have in-house FMF approved platform. But if you are giving to outside, you should have, there are only 3 lab platforms that are approved by FMF. So it should be one of them. There are only 2 softwares that are approved. It should be one of them. So be aware of that. Again, audit your screen positive rate. Keep updating and upgrading your program after careful evaluation of robust evidence. Thank you very much.
Thank you, Dr. Manikanandan, for a detailed review of the subject. And really, you have mentioned your screening protocol, which will guide us. Can we have some questions? No? Okay, we'll have questions at the end of this session.
When to worry and when to reassure. Welcome, Dr. Bhandari.
Very good morning to everybody. At the outset, I'd like to thank the organizing team for giving me this opportunity.
She is working very well. We are very proud of you, what you are doing.
Thank you.
We welcome you.
So it's always, sir, and it's always a privilege to come back to your city where you actually trained from. So I really hope to see all my mentors today and meet them after the conference is over. So good morning, everybody. I am Dr. Shweta Bhandari. I run a maternal fetal medicine unit at Indore. The name is Ayushya Center for Fetal Medicine, and as Manikandan sir has already made my job quite easy by discussing the various soft markers that we look up on the second trimester scan, I would straight away come to the discussion and the importance of each soft marker now. So many a times we come across patients who have missed their screening in the first trimester and they would report to you for the very first time in the second trimester. So obviously then you have the options of offering them a quadruple marker test along with a genetic sonogram, because independently both of them do not have a very great accuracy or a detection rate for picking up trisomies or aneuploidies. So why should we offer genetic sonogram? Because of course, apart from the routine structural assessment that we perform in the anomaly scan, we look out for soft markers. This helps us assess the risk for aneuploidies, and these markers increase the detection rate and they decrease the false positive rate. And so far, combined test is the best test that we have discussed. Of course, the most cost-effective test as well. Though now this statement would stand falsely, because we know that NIPT is by far the best screening test that we have available for singleton pregnancies and twin gestation both. And those women who have had a combined test, the genetic sonogram acts as an add-on test for improvising on our sensitivity and detection rate. So the various soft markers that we assess on the ultrasound is, first of all, we look for mild ventriculomegaly. And to assess ventriculomegaly, we have to have the correct sections of the fetal head. And the ventricle has to be measured at the level of the parieto-occipital fissure. And the maximum width here is supposed to be measured. We would then classify it as mild, moderate, or severe. As far as moderate and severe ventriculomegaly are concerned, they have different implications as compared to mild ventriculomegaly. The second soft marker that we would commonly look for is short long bones, the short femur, short humerus. They act as markers for Down syndrome and aneuploidies. Then you have aberrant right subclavian artery. We will discuss this once we have a case to discuss about it. So the aberrant right subclavian artery is basically a different origin of the right subclavian artery, and it doesn't arise from the usual site, and it has usually, the course that it follows is behind the trachea. So we usually see a retrotracheal vessel here, as you can see on the 3-vessel view. And when you see this retrotracheal vessel, it kind of gives you a clue that there is an aberrant right subclavian artery. Then we would look at, for pylectasis, we look for the dilatation of the renal pelvis. The very common intracardiac echogenic focus, to which we do not give importance or weightage these days. and then echogenic bowel, again, which is a very vague finding, I would say, but then you have to evaluate the fetus correctly to see what importance does it carry for this pregnancy. So this meta-analysis was published long back, 10 years back, and in which they studied which soft marker actually carries a greater weightage as compared to the other ones. And in these soft markers, they studied the positive likelihood ratios and negative likelihood ratios attributed to each of these markers. And of all the markers that stood out most importantly were mild ventriculomegaly, increased nuchal fold thickness, the aberrant right subclavian artery, and the absent or the hypoplastic nasal bone, because as you can see, even as an isolated marker, the risk increase is greater with these 4 markers as compared to the rest of the markers. So if you have no markers on the ultrasound, there is a 7.7-fold reduction in the possibility that the baby would have a Down syndrome. So coming to understanding what these likelihood ratios means, we usually in statistics use the Bayes theorem, and we would use the positive likelihood ratios of the markers present and the negative likelihood ratios of all those markers absent, and then incorporate these into the algorithm to get a final estimated risk. So we have understood the concept of a priori risk. This a priori risk is basically in a woman who comes to you for the first time without any screening test is her age-related risk. However, if she has had a combined first trimester screening, then the final risk estimated on the combined test becomes your a priori risk for the second test that you would now be conducting. So the a priori risk multiplied by the likelihood ratio gives you a final risk assessment, and based on the category into which it falls, whether it's a low risk, intermediate risk, or a high risk, you would then offer her further testing. So, all right, so looking at this example, if you see that the intracardiac echogenic focus is absent, the hydronephrosis is absent, short femur is absent, but if an echogenic bowel is present and ARSA is present, the positive likelihood ratio comes to 30 or something. And therefore, then we would use this likelihood ratio combined with the a priori risk and then estimate a final risk for Down syndrome. So once you have that risk, so the a priori risk that as I discussed with you, it could be the result of the combined test, the quadruple test, or just the maternal age if she's not had any biochemical screening. Then you use it to estimate a final risk, and if it is high risk, you would offer them invasive testing to find out whether the baby is actually affected or not affected. So the markers which warrant testing are ventriculomegaly, aberrant right subclavian artery, increased nuchal fold thickness, and absent or unossified nasal bone. So these 4 markers we are much more concerned about as compared to if I would see an echogenic focus, isolated echogenic bowel, isolated short humerus. But in conjunction, you have to look at the anatomy of the baby overall before we come to a conclusion that this is something that's less important and this is something that's more important. So let's discuss this in terms of cases. This is the first case. This is a 30-year-old lady. She was referred to us at 21 weeks of pregnancy. She's a primigravida. She was already screened positive for adverse syndrome in the combined risk assessment. The risk was 1 in 12, which is pretty high risk. So what additional information would you need to make a management plan in this pregnancy? So I believe we would first like to know whether she's had a proper anatomy assessment at the antenuchal scan or not, because trisomy 18 and trisomy 13 are abnormalities which was present with very gross or easily picked up structural abnormalities even on the first trimester. And then, of course, look at what lab it was done, whether it was from a standardized lab or not. You would go and look back at the multiples of medians of PAPE and beta HCG. So as you can see here, the free beta HCG was 0.1 moms and PAPE was 0.25 moms, which is quite suggestive of a trisomy 18. But then additionally, we would now like to have a good detailed ultrasound scan for her to understand what are the possibilities that the baby has a trisomy 18. So we did an anomaly scan. We could see bilateral choroid plexus cyst. There was early onset fetal growth restriction with uteroplacental insufficiency. There was hypotelorism. The skin fold looked thick, but it was coming okay on the nomograms. So what would be the further management plan? Once you know that on the ultrasound you see features of trisomy 18, you have a screen positive test in the first trimester itself, of course then you would want to confirm it before you tell the patient that whether the baby is affected or not. So we offered her invasive testing and the fluid came out positive for trisomy 18 and the fetus was affected with trisomy 18. So we know that trisomy 18 in this case could have been picked up maybe at an earlier gestational age, had a good anatomy assessments can be performed in the first trimester itself. And the common ultrasound features that are suggestive of trisomy 18 that we should all be seeing on the scan are abnormally shaped heads, which is a strawberry-shaped head you see classically in them, choroid plexus cyst. In the second trimester, you would additionally see very gross abnormalities. I mean, it's very less likely that a baby would look normal on the ultrasound and the baby would have T18 or T13. So absent corpus callosum, enlarged cisterna magna, facial clefts, nucleedema, single umbilical artery, abnormalities of the kidney, hyperechogenic bowel, growth restriction, shortening of the limbs, and other structural skeletal abnormalities. So coming to the second case, this is a 32-year-old primigravida. She comes to us for the first visit at 19 weeks. She's not had any prior screening. And when we do an anatomy assessment, these are the findings that we could see. So there was a unilateral cleft lip. There were bilateral choroid plexus cyst. There was a hyperechogenic bowel that you can see, but the palate was, however, intact. So what, in your opinion, should we be doing? Should we be offering her quadruple marker or NIPT or invasive test? Invasive, right? Because when you see a structural abnormality, obviously you are going to think beyond aneuploidies. There could be other concerns as well with the baby. So the possible etiologies in this could be genetic abnormalities. It could be related to some environmental factors. It could be related to certain drug exposures, teratogens. So what tests would you then offer to the patient? Once you do an amniocentesis, what do you think you would subject the fluid to? Which kind of test would you think of? Sorry, I didn't get you. Right, so you would, of course, I mean, we would know that unilateral cleft lip palate could be associated with, apart from aneuploidies, there could be other microdeletion syndromes or duplication syndromes which could be associated with it. So we would first do a detailed ultrasound examination. We would do invasive testing for a microarray maybe. And also in our practice, we do a DNA storage for all structural abnormalities, because sometimes there could be certain single gene disorders which are causing these abnormalities in the baby, and they would not be picked up on a microarray. So that option should always be there, that we do a stepwise approach kind of. So we first do offer them QFCMA, and then if they agree to, after a proper counseling, that there could be certain disorders that could be missed on a CMA, and if they agree to it, we do offer them a whole exome sequencing as well. Because we know that there are certain genetic syndromes like the Goldenhar syndrome, Treacher-Collins syndrome, and Pierre-Robin syndrome that are known to be associated with the cleft lip and palate. So I would not go into much greater details of what is cleft lip, but it is something that we should all know that it has got all kind of inheritance. It could be autosomal recessive, it could be autosomal dominant, X-linked recessive, X-linked dominant, and sometimes therefore we should offer exome sequencing ideally to all patients. And I do not know how many of the patients would actually opt for it, because these tests are expensive as well. So the patient turned out to have a normal CMA, and but still I think she discontinued the pregnancy, thinking that we do not want to take a chance that the baby might have a single gene disorder later in life, because they could not afford a whole exome sequencing. So the recurrence risk of cleft lip is about 5% if one sibling or parent is affected, but it increases to about 10% if two siblings are affected. The prognosis is usually good in the absence of associated structural abnormalities, and surgical repair is then suggested at 3 to 6 months of age, and you have to involve them involved in the counseling that the baby may require later on speech therapy, the baby may have certain dental problems or feeding difficulties in the initial months of life, and all this should be a part of the counseling, and therefore we should always involve the maxillofacial surgeon also when we are counseling such patients. So the idea of putting up these 2 cases of choroid plexus cyst was that usually choroid plexus cysts are benign if they are isolated, but we have to look for additional ultrasound findings when we are screening these patients. And if there are additional ultrasound features, we have to keep in mind that there could be things beyond aneuploidies, there could be things, apart from what we have in mind. So we have to do a proper anatomy assessment and then counsel the patients. So even cleft lip and palate can be diagnosed early now at 11 to 13 weeks. There are markers that we would look for the maxillary gap or even in the retronasal triangle. So a good anatomy assessment scan at 11 to 13 weeks is what we now all aim to as fetal medicine consultants. So the future care plan in pregnancy would be routine obstetric care for her and just a prenatal consultation with multidisciplinary with the MDT team makes things easy for her to finalize on what she decides to do ahead in the pregnancy. So the third case, this is a 25-year-old primigravida. This is a spontaneous conception. She was referred for a second opinion in view of this concerning finding of an absent nasal bone. She's not had any biochemical screening and now she's 21 weeks of pregnancy. So what would you like to now do? Would you offer her an NIPT? Would you offer her invasive testing? What would be on your mind now? Invasive straight away. All right, so because we know that NIPT is good at picking up the common aneuploidies, certain microdeletions which are yet to be validated for the NIPT to be used as a screening test for those microdeletions, but an absent nasal bone is something that could be associated with things beyond aneuploidies. So usually in my clinical practice for an absent or unossified nasal bone, we would always offer them an invasive testing. So we did the same. We offered her a fish. The fish came out to be normal. But when we did a CMA, the chromosomal microarray, what we could pick up was a 13q deletion. But finally, the impression was that it was a variant of unknown significance. So now when you have a variant of unknown significance, you have to understand these mutations and kind of make use of this information in counseling patients as well. So we know that the mutations could be pathogenic or likely pathogenic, in which we know that they are disease causative and the fetus is likely to be affected. Then you have variants of unknown significance regarding which we do not have enough literature available, so what we can use in counseling. And then there are likely benign variants or benign variants, which we know for sure that they are unlikely to result in any phenotypic abnormalities. So the fetus now had a variant of unknown significance. So how do we go about counseling these parents? So we would always involve the clinical geneticist in our management plan. And we tested the parents to understand whether the parents also harbored the same mutation or not, because if they had the mutation and they are apparently okay, then the baby would have been fine. But what it turned out to be was that the parents did not have the same mutation, and it was actually a de novo mutation. And for de novo mutations, we usually suggest that there is a good probability that the fetus might have these symptoms, but we still are not very sure. Based on a vows, we do not tell them that the baby will be affected and you have to terminate the pregnancy. So you're then kind of stuck with these variants of unknown significance. So we did a genetic counseling for her. The fetus had a 1.2 MB deletion on 13q gene, and these were the syndromes that were listed in this gene region with spinocerebellar ataxia, developmental delay, and we involved all this information in counseling the parents. The parents, however, wanted to continue the pregnancy, and I think she's yet to deliver maybe. So once she delivers, we would know in long term how the baby behaves. Coming to the fourth case, this is a 28-year-old lady. She's had one normal vaginal delivery, a living issue, 4 years old. The second baby had tracheoesophageal fistula, died after 4 days. She had a spontaneous miscarriage, and again, this was on the combined FTS. As you can see, the nasal bone is unossified. she turned out to be screen positive for Down syndrome. So what would we do, NIPT or invasive? Invasive, okay. So that is what we did. We did a chorionic villus sampling. The fetus was affected with trisomy 21, and the parents opted to discontinue the pregnancy. The fifth case, another interesting case. She had the first child was born vaginally, apparently okay, but then had aspiration because the baby had a cleft palate. The second baby was apparently fine, is a living issue. The third pregnancy ended up in a second trimester termination because the baby had Edwards syndrome. This was a fourth pregnancy. She had a low risk combined FTS on dual marker and the NT scan. The target scan was done at 19.6V, and what we could see was a aberrant right subclavian artery. So we know that the aberrant right subclavian artery has got a different origin and it follows a different course as compared to the right subclavian artery. And now with this particular obstetric history in mind and with the aberrant right subclavian artery noted on the anomaly scan, what would you then counsel the patient for? In this case, you feel you would, I think the current, what I do in my clinical practice is that I give them a cafeteria approach, that this is one test which would test for all these things. This has got a limitation that it would pick up on all these problems, might miss out on all other problems. The invasive test is a diagnostic test. It picks up almost all genetic problems, but never 100% assurance. The patient, because of a previous obstetric history that one baby had a cleft palate, the other one had Edwards syndrome, she wanted 100% confirmation this time. And surprisingly, the baby had a Turner syndrome. It was a monosomy X. It was a mosaic monosomy X that turned out to be on the CMA. No. It was a mosaic Turner's, ma'am. It was a mosaic Turner's. The baby had only an ARSA, so we did invasive, and luckily we picked up the mosaic Turner. Yeah. So as far as aberrant right subclavian artery is concerned, whenever you see an aberrant right subclavian artery on the target scan, it could be seen as an isolated finding. It could be a part of congenital heart disease, or it could be a part of genetic syndromes. And in this paper, this Chinese paper that was published, they did a retrospective study, and they found not only trisomy 21, 18 or DGeorge syndromes, but they also found other mutations associated with an ARSA. And the conclusion in their paper was that if the fetus has an isolated ARSA, the probability that the baby will have a copy number variant was about 4%, whereas those with non-isolated ARSA had a 9% probability of another pathogenic CNV. So overall, the percentage that they quoted was 7%. So we should always counsel parents that NIPT is not the 100% diagnostic test, because later on, if it turns out to be some other genetic syndrome, we have to give the parents all the options that these are the tests available, and these are the pros and cons of each test available that you can actually think about. So I think I'm running short of time. I'll have to skip on the last two cases. And I think we have one more case I can take. All right, okay. So this is the sixth case. This is a 31-year-old primigravida. She was referred to us at 22 weeks of pregnancy. She was intermediate risk for trisomy 21 on combined FTS. The target scan was otherwise okay, apart from mild bilateral pylectasis noted. And we did a sequential screening in terms of combining the result of the first trimester with the second trimester genetic sonogram, and she fell into the intermediate risk. So what would you now counsel the parents for? She was intermediate risk on FTS. Even after combining the genetic sonogram, she's intermediate risk. So again, we look at the previous screening results, look at the moms of the biochemistry that were incorporated, additional ultrasound features if there are any, whether there are any other associated abnormality, and adopt the cafeteria approach for counseling and involve the MDT team for obviously not the mild pylectasis, but for the moderate to severe ones. The most common etiology associated with urinary tract dilatation is that they are in 50 to 70% cases are transient or physiological findings. However, there could be other conditions that could be could start manifesting as UTD, and you need to follow them up for all these evolving abnormalities. And you would classify pylectasis into mild, moderate, or severe pylectasis. But only classification is not important. What you have to look is that you do a proper anatomy assessment. You look at the kidneys in much greater details, see whether it's unilateral, bilateral, look at the cortex, look at the degree of the dilatation. How does the amniotic fluid volume look around? How is the urinary bladder looking? Is there any bladder wall thickening, any associated ureteral problems, associated abnormalities? And if none of these are found, then obviously you can offer her either a NIPT or invasive testing, telling the pros and cons of each test. The patient opted for an invasive, and we did a karyotype, which was absolutely fine, and the patient had ended up having a live birth, which was okay. This is the last case. So this was a 36-year-old primigravida. She spontaneous conception. She was referred to us in view of screen-positive combined FTS. She had a target scan done outside, which was reported as prominent ventricles. She did a NIPT as well because of the screen-positive FTS. The NIPT was low risk, and then she came to us at 22 weeks when we scanned the fetus. But what we could see was something apart from the ventriculomegaly, and there was an absent cavum septum pellucidum, which kind of raised a suspicion for us that there could be additional neurological abnormalities also in this patient. So when you have ventriculomegaly, you have to think of all possible etiologies that could be linked to ventriculomegaly. It could be fetal genetic disorders. Fetal infections could also present as fetal ventriculomegaly, especially toxoplasmas and CMV. There are possibilities of fetal neuronal migration disorders, which may not all be picked only by an ultrasound. Intracranial hemorrhage, and many a times idiopathic. We do not know why there is a ventriculomegaly. So as a part of ventriculomegaly, what we would do is that you first see the degree of ventriculomegaly, whether it's mild, moderate, or severe. 10 to 12 is mild, 12 to 15 is what we call as moderate, more than 15 is what we call as severe ventriculomegaly. Look at the other systems, of course, CNS and non-CNS abnormalities. And what is quoted as a normal neurodevelopment is that if it is an isolated mild ventriculomegaly, by isolated I mean you've ruled out all other possibilities to the best possible extent. Usually they will have a good outcome, more than 90%. And you would do a good neurosonography, a detailed anatomy ultrasound, karyotype and a microarray, maternal infection screening to rule out maternal viral infections, and involve the multidisciplinary fetal neurology team in decision making finally. So a neurosonogram was performed for this patient. What we could observe was the CSP was not there, was bilateral ventriculomegaly, and the corpus callosum looked thick, short, and dysgenetic. And we offered her finally an invasive testing because we had to understand the etiology. The fetus had two mutations. One of them was a pathogenic mutation, the other one was a likely pathogenic mutation. One of them had a dominant inheritance, and they were both related with multiple system abnormalities on understanding the phenotype. This patient opted for a termination of pregnancy. However, we did counsel the parents to be screened for the mutation because one of the inheritance was not very clear and associated with one of the genes. And that is what we counseled them for finally. Can I go ahead with one more case, or we are running short of time? Okay, fine. So I'll end up here, and thank you very much for your patient hearing.
Thank you, Dr. Shweta, for your very insightful description of soft markers. And we would like to have one or two questions from the audience. I want to know here in the hall there are many practicing gynecologists, not all are fetal medical specialists. So in which cases you will directly go for NIPT if a patient comes in second trimester with soft marker positive, if it is 1 positive, 2 positive, or what are the markers in which we should go for further testing of the parents?
Okay, so presence of a soft marker does not directly tell us whether we should screen the parents or not, but the 4 soft markers that we are much more concerned about, ma'am, are anossified or absent nasal bone, the presence of an aberrant right subclavian artery, increased nuchal fold thickness, and ventriculomegaly. So usually these 4 markers we do not leave uninvestigated, and we don't rely on a NIPT completely to understand that the baby will have a good prognosis, because it could be beyond aneuploidies, these 4 markers could be associated with. So for these 4 markers, we usually offer invasive. As far as the other markers are concerned, we would like to understand the quality of the scan, whether it is a good scan quality or not. Everything has been taken into consideration when we are saying that it is the baby is structurally normal and only the biochemistry is positive, but then we would like to have a sequential screening done to understand what the final risk is. If it is a low risk, we do not further investigate. If it is intermediate risk, we offer an IPT. If it is high risk, we offer invasive testing.
And in sequential screening, what are your, division? It is same 1 in 250?
So, on sequential screening, we would say maybe until 1 in 100, but now they have further reduced the cutoff to 1 in 10. I think, Manikandan sir, what do you want to comment on this, sir?
I'll keep it short. So, for ventriculomegaly invasive, for unossified nasal bone, when they are apparently normal, NIPT, aberrant right subclavian artery, if the palate and thymus are okay, NIPT, otherwise invasive. For echogenic focus, we don't report. For echogenic bowel, we considered everything. If its content of the bowel is echogenic, invasive with CFTR gene mutation also. For mild hydronephrosis, no invasive, no NIPT. For short long bones, if the screening has been done, it's normal, no further testing. These are all for action that we take for isolated. Now coming to the point was...
One question, Dr.
Cutoffs.
For suppose the nuchal fold is borderline, or the, you can say ventriculomegaly is borderline. So how long you follow and how long, you can wait for other tests?
Borderline, there's a clear cutoff, madam. 10 mm and more, you have to investigate. 6, that is for ventriculomegaly. 6 mm and more, we have to investigate. What investigation I just told. And we don't do sequential, we don't do the traditional or the purest way of sequential. In the first trimester, some lab reports intermediate risk. Those labs we write a letter, don't report. We don't want that.
So what levels you are taking as per you? It is
1 in 250 at term. So in the software you can set the cutoff 1 in 250 at term for trisomy 21. As I said in my lecture, we don't bother about trisomy 18 or 13.
Yes.
Shweta showed, they will always find out.
Yes. And by setting this 1 in 250, have you been able to reduce the number of invasive testing?
Yes.
The test, yeah. So I published the data from Mediscan when I was doing my fellowship. We analyzed 27,000 pregnancies with this protocol. The protocol that I just showed, the invasive rate is about 1.8%, which is on par with global standards. And when you use this protocol, every 23rd amniocentesis will yield you a result. That means the odds of being affected given a positive result, OAPR, is 1 in 23. You need to do 25 amniocentesis with this protocol, 1 in 250, you will find a Down syndrome.
And how you do post-counseling of positive cases?
Okay, so I think that Turner syndrome case was a very good pickup. We would also offered, we would see if it's a female fetus, then we will tend to offer invasive because we know aberrant right subclavian. So it depends on the situation. So we do a pre-test counseling first. So what we are looking for, what are the possible things, and the tests, whether it is good to detect them or not. So that pre-test preparation is very important. And once we have the result in hand, let's say in the Turner's, the outcome of a Turner's mosaic will depend upon the proportion of Turner cells in the given. So either FISH or QFPCR would tell us that. What is the proportion? Anything more than 30% and above is a bad prognosis in Turner's or in Down syndrome mosaic. Pure trisomy is always bad only. And even that WUS that she told, 1.3 MB deletion in chromosome 13, we would have still counseled as bad only, even if the lab gives us WUS. So depends, we also go through the report, just not based on the lab's definition of whether it's pathogenic or not.
And, sir, what are your guidelines regarding NIPT in vanishing twins?
We don't.
Don't
we
do,
don't,
don't,
don't offer.
don't do. If you have seen twins and it is one of them is miscarried, don't do NIPT. If there is a reason to ask the question, is the chromosome normal, put a needle.
Also, the last update from the FMF regarding the cutoffs and then further low risk.
Yeah,
but
so
it's
the-
their cutoff and their labs are quite standardized. I don't know, but there is a variation.
The 1 in 20 we arrived because the positive predictive value is the same at 1 in 20 between combined screening test and NIPT.
Okay, thanks.
So we are entering into a very great reporting that intermediate risk, because as a gynecologist, as a OBGYN practitioner, ultimately onus comes to the OBGYN and you have to give an answer. So what I practice, what you practice, what Shweta practice, what people practice, it is you that you decide what is correct. You cannot put a set of protocol sort of thing where you are practicing, how government is supporting, if you read the papers and all. So there are first time screening, if you go with the recent 24 ISPD journal, there are 4 scenarios. Yesterday we had discussed with an IPD workshop. The things are, whatever the consultants they are telling, even though he is telling that 1 in 250 should, between 250 and 1000, there should not be any intermediate risk sort of thing. Things are confusing. You have to tell that to the patient, first counsel the practitioner, then practitioner will counsel the patient, then there will be output. So it is an individual way of wisdom, what you are doing with, how you are handling with the patient. And if you have any confusion, ask them. That is the basic motto of this FetusCon. So thank you very much, Shweta and Mani. We will have more discussions. I request Komal to start with the
As we are
inauguration.
towards the end of our first session, I would like to, of the first session, please come forward. And I would request Malhotra ma'am and Rupa Sarkar ma'am to please felicitate our chairpersons of this session. I would request Rakhi ma'am and D'Pankar Banerji sir, please come forward also.
We will have inauguration. I request Komal and Rakhi to start with the inauguration, and we will finish it when we will start our next session by 11:15. Please go ahead.
All speakers and dignitaries, please come forward for the group photograph after the inauguration, please. Sneh ma'am, Devani ma'am, Neeta Shukla ma'am,
Amongst us, Dr. Kavneet Khanna is with us. Very hard-working girl. She is a professor and director of Sukh Medical College. Have a dental surgeon, MDS, but I am thankful to कि fetal medicine conference में आई है to see what we are doing and how we integrate with her college in our institute so that we can have a genetic and fetal medicine unit later on. I think
शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदाम् जाड्यान्धकारापहाम् हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्
Sangeeta ma'am. I would request Sangeeta ma'am to felicitate our. Yes.
ये हो जाने हो
हाँ.
नहीं और कोई नहीं
नहीं वो felicitate.
हाँ चल अभी रुक जाओ 1 मिनट हो जाए फोटो हो जाए पास में
अब आए फोटो में.
चलो ले लो फटाफट फिनिश इट Thank you.
I would request Sangeeta ma'am to please felicitate Manikandan sir.
We will felicitate our
Speakers.
now and then we will continue with our
On the stage? Okay. हाँ.
stage पे आ जाए stage
गीता गोइन मैम नहीं आए ना. Rajana Gupta ma'am and Dr. Bhavna Mishra ma'am as the chairpersons to come forward for the second session. Dr. Rita Shukla ma'am, Dr. Ranjana Gupta ma'am and Dr. Bhavna Mishra ma'am. Please chair the session. The speaker for this session.
Good morning all. Now we proceed to giving his views regarding algorithms in fetal growth restriction, diagnosis and timing of delivery. I please request sir to give his precious views regarding the topic.
Let's move on to actually the most important component of fetal medicine and your obstetric practice, understanding of which will help you prevent the one thing that every obstetrician fears, that's a stillbirth. We don't want that to happen, and it's closely tied to fetal oxygen status. And fetal oxygen status is closely tied to fetal nutrition status. And fetal nutrition status is closely tied to how the placenta works. And how the placenta works is dependent on many factors. But we can put all of this together into 3 simple algorithms that you can print it, keep it in your desktop and follow it, and I would dare say that you would not have another stillbirth. Let's dive right into it. If you understand what demands the fetus puts on the placenta, there are only 2 types of demands. One is nutritional, and
I request audience, it is a very important topic. I know the previous session was little bit, you want to get little bit relaxed, but Dr. Mani is with a very important topic, and I request you please keep a silence.
all right, thank you sir. There are 2 demands. One is nutritional demand, the other is oxygen demand or respiratory demand. Now, these demands don't have any linear relationship with increasing gestational age. As the baby grows, there is more demand. It's not like that. If you look at the nutritional demand chart, the demand increases early in pregnancy, right from the second half of pregnancy, 20 weeks onwards, and then it keeps increasing throughout the early 3rd trimester and then plateaus down. Whereas the oxygen demand doesn't rise until the 3rd trimester, but then escalates very fast. Exponentially, it keeps increasing until the point the mother cannot satisfy this demand and she gives birth. So remember, when we were postgraduates, for those of my batch and senior, we thought the date of birth was decided because the head cannot grow beyond that and it can't pass through the pelvis, the great obstetrical dilemma. But recent research points towards that the maternal basal metabolic rate can only go 2 times the normal, and beyond that it cannot support the fetus, and that's why they give birth. So the oxygen demand is exponential in the 3rd trimester, but doesn't start until late 2nd or early 3rd trimester. It's a very important concept. Now, how does the placenta meet this demand? Early in the first half of pregnancy, it simply gets more blood into the system. So the intervillous space gets more blood by transformation of the uterine arteries into uteroplacental conduits. So that's the first step. So that's called uteroplacental transformation. And simultaneously on the fetal side, the fetus puts more branching, more villus, that is called villus arborization. So these 2 mechanisms ensures sufficient perfusion into the intravillous space, perfusion. So the first half of pregnancy, the demands are met by increasing the perfusion. But this is not enough to give or meet the demand of the second half, which is the exponential oxygen requirement. Here the placenta does a nice little trick. All the villi will undergo very minute changes. They thin out. The placental barrier, the exchange barrier thins out such that it becomes very thin and multiple microvilli. And inside the microvilli, the capillaries also thin out and dilate, so they become sinusoids. So a thin membrane, a sinusoidal capillary, thin perfusion gradient, and slow flow of blood. So the oxygen transfer increases dramatically. So the second half, the placenta does a trick. It's already formed, it's well perfused, but it does undergo villous maturation, and that is called as ultrastructural changes. That happens in the second half. And when ultrastructural changes happen, there is not much change that happens in the perfusion. So your umbilical artery resistance will be normal. It's a very important concept for you to understand why fetuses die late, why late stillbirth occurs. If you don't understand this concept, you will miss identifying late FGR. So this is called ultrastructural changes and typically happens in the third trimester. Now, when these changes, perfusion and ultrastructural change will increase the diffusion. So when perfusion and diffusion don't happen well, you will get fetal growth restriction. When the problem in the placenta happens early in the gestation, first half, then it is a problem of perfusion, not blood, enough blood coming into the intravillous space. So you will see the footmarks, you will see the pug marks of that disease. You will see the uterine artery showing high resistance and the umbilical artery showing high resistance. So these are all footmarks of perfusion. But when the placental disease happens later, initially the placenta is well formed, but then later the ultrastructural change doesn't happen, will you get problems in perfusion? Will you get evidence of perfusion problem? You won't. The uterine artery may remain normal, umbilical artery may remain normal, and yet the baby won't get enough oxygen. That's when the stillbirth happens. So problems of diffusion happens when the ultrastructural changes fail to happen, and then there is you will miss it because you don't have ultrasound evidence of high uterine artery or umbilical artery resistance. This is a key concept that you should understand if you really want to prevent stillbirths. Now, let's put all these things into algorithm as I told. The first algorithm is asking the question, I have done a target scan, when should I call her back for the growth surveillance? That's the most important algorithm that we should learn. That depends upon what we understand as risk factors for IUGR. There is an obstetric history. How did you perform in your previous pregnancy? What is your medical history? Do you have hypertension, type 2 diabetes? And what is the current clinical? Is the fundal height lagging? Are you malnourished? Are you having repeated infections? These are all traditional risk factors. But there are also newer risk factors. We talked about serum screening. Those markers are derived from placenta. So if you have a screen positive pregnancy, but it became normal on amniocentesis, that placenta is not going to perform well. So remember that. Any screen positive is a risk factor for FGR. And we also talked about uterine artery I showed in my protocol. Uterine artery perfuses the placenta. So if the uterine artery has high resistance, that means high PI, that's a problem later. And the crux of the problem itself is placenta. So look at the placenta in the second trimester also. If you see a bad placenta, I will show you some examples, then that's a risk factor for FGR. Now, all those risk factors don't go together. Some are very high weightage. For example, what did you do in the last pregnancy? Obstetric history. Biomarkers are very high importance. Uterine artery have high importance. Rest all have medium importance. Now, look at this placenta. This placenta is very small and this placenta is very bulky. The normal second trimester placenta is the South Indian Uthapam. It should be neat, long, tapering at the edge. Have you seen? No? It's a nice dish. So it's a thick, much thicker dosa. So it should be like that. So next time when you scan, look at the placenta. A normal placenta should be granular, nice and neat, long, tapering at the edges. This is not even long and this is too bulky. It's as thick as it is long. These are problems. And then there will be some placenta which will look like containing jelly, which the radiologists usually report as intraplacental hematomas. They're not. It is an expanded intervillous space, a dead space. These placenta are risk factors. Small implantation, and these two are called hyperinflated placenta. They are risk factors, so remember them. Uterine artery can be used to assess how much the first component is doing well. First component was uteroplacental transformation. So if you measure the uterine artery Doppler on both sides, average it, if the mean resistance PI is higher than the 95th centile, that's a problem. So you should do it in all target scan simply to know when to call her back. Now, so with all this information, the first algorithm that we should know is when to time the growth surveillance scan. You have done a target scan, report is fantastic, baby is so clean, everybody is happy, but what is lurking around is the risk of FGR. So, clinical risk factors, what we discussed before, uterine artery Doppler, look at her first trimester screening. How is the PAPE? If you have done a PLGF, was she screen positive for preeclampsia? Then look at the placenta itself. If no risk factors at all, and if it's a clean baby and a nice plumpy baby, at the target scan itself, the AC is more than 50, your clinical surveillance is enough. Do the symphysiofundal height, maybe at 36 weeks, we can do a scan. Nothing will happen. You can be sure about it. But if the baby is not so plumpy, then maybe bring that scan to 34 weeks. This is what we advise. We don't give 4 weeks later to everybody. We don't do that. Then if there is one risk factor in this whole category, then you ask, is the baby reasonably grown well in the target scan? That means 25 centile and above. Yes, then call her back at 32 weeks. That's enough. If no, call her back a bit before at 30 weeks. But if there are more than one risk factors, this is something you should not leave at all. Look at the AC. Already the baby is showing small size, AC less than 10 centile. Call her back at 26 weeks, I call back because my NICU in Pondicherry will support from 28 weeks. So I see at 26, if it's severe growth restriction, I'm ready. I can also prepare the mother to be ready. If it is okay-ish growth, not less than 10 centile, then we can call her back at 28 weeks. So the first algorithm tells us when to call for the growth surveillance. That's where it starts. You don't want to miss the growth retardation, growth restriction, even before you called her back. Now let's look at how to derive an algorithm for diagnosis. When you want to think of fetal growth restrictions, 3 things should be there in your mind. One is, it should be a small baby. It need not be small compared to the reference chart. It can be small on its own also. I'll explain that. Then it should, because it's not deriving enough nutritional support, it should show some physiological adaptation. And then the cause of this should be a problem with the placenta, not some chromosomal, not some malformation. So you should have these 3 evidences. Then you can think of FGR. It's very important that you use the word FGR very selectively after you have enough evidence. So let's look at fetal size. You can see here the EFW, estimated fetal weight, is less than the 10th centile. This is small fetus. But in the next one, you see that the EFW is less than the 1st centile. That is very small fetus. Here, the EFW was okay, but compared to its own target scan size, the abdominal circumference has plummeted. So this is also small, but relative to its own size, it's small. So this is RSGA or relative SGA. So we have SGA, VSGA or SSGA, we can say RSGA. So SGA is the first step. You need to know if the baby is small, either by the whole population compared to the whole population or relative to its own size before. Now once you have size sorted out, then you look for placental disease. As I told you before, you look at the placenta itself. The placenta is bad, that itself is evidence of placental disease. Otherwise, the classical evidence for placental disease is uterine perfusion. So the uterine artery perfuses by dilating. So it has to have a low impedance, low resistance. If the uterine artery mean PI is high resistance, that is evidence of placental disease. You can also check the umbilical artery. If that is showing high resistance or absent end-diastolic flow or reversed end-diastolic flow, all are evidence of placental disease. So this whole slide is evidence of placental disease in addition to looking at the placenta directly. And when you look at the placenta, if the placenta is a badly formed placenta, then you may have three patterns. The first pattern is diffusely bulky and very much non-granular. So this is called subchorionic fibrin deposition, and this is associated with distal villus hypoplasia. You may also see the jelly-like pattern that you showed before. So when you see this kind of placenta, take it as evidence of placental disease. So then we move on to adaptation. I told you the fetus which doesn't get enough nutrition will be showing some adaptation. There are a lot of adaptation, but the one that is clinically useful for us is the so-called brain sparing effort, where the baby, in order to get more oxygen to the blood, will lower the resistance in the cerebral circuit. Therefore, the middle cerebral artery diastolic flow will increase. So, how to make an FGR diagnosis? Depending on when you meet the criteria, when you meet the criteria before 32 weeks, it is an early FGR. When you meet it after 32 weeks, it is a late FGR. Sometimes overlap will be there. So the first question, it always starts with what is the size. Very small size, but otherwise clean baby, almost always placenta only. You can directly say it is a FGR, early or late. If it is just small, SGA, but you have to ask the question, is there evidence of placental disease? That means you should ask, give me the umbilical artery and uterine artery PI. And they give you the value, more than 95th centile, small plus this, okay, this is FGR. Now, if it is just relatively small, again you ask the question, is there an umbilical artery, uterine artery problem? If it is there, it is FGR, but in most cases, in relative smallness, which occurs late in the third trimester, you won't find evidence of poor placentation. Why? Because it's a problem with diffusion. The perfusion has already happened, and perfusion is the one which we are testing by Doppler. In these cases, you would look for fetal adaptation. The baby is not getting enough oxygen because there is poor diffusion. It would alter certain things to adapt. So look at the brain perfusion, and when there is a low resistance in the middle cerebral artery or its cousin, low CPR, on the background of a relative SGA, then that is a fetal growth restriction. Look at how I have put it selectively, that FGR word on the late, because this subset is usually in the late category. If you have severe placental disease like AEDF or REDF, always it's going to be a FGR, but that's usually a problem in the early phenotype. Get it? So in the late phenotype, you will have normal umbilical artery. If you have an abnormal AEDF, REDF situation, that is usually an early FGR. So if you can correlate with the first slides, then it's good. Okay, now let's go to the management itself. The principle of management we all know. Balance prematurity versus hypoxia. You want to avoid stillbirth. You should monitor mother and the fetus. The fetal medicine team should be monitoring the fetus once the question of FGR has come, but the mother has to be monitored by the obstetrician because there is a risk of preeclampsia. You have to time your steroid well, very important. Steroid you can't keep on giving, it will burn the baby's brain. And in many cases, you would have to do an in utero transfer. Don't deliver outside and then shift to an NICU. You also have to give magnesium sulfate when you are delivering before 32 weeks, and you have to deliver it in a timed manner, allowing as much maturity but not hypoxia in a setup where there is an NICU. We know the deterioration and therefore we can use the cascade. I will tell you how. If you have made a diagnosis of early FGR, the monitoring tools is umbilical artery. Umbilical artery, umbilical artery, umbilical artery. Every week you do the umbilical artery. Once it turns AEDF, then you switch to ductus venosus and CTG. The CTG is only for knowing if there is a spontaneous deceleration. BPP is not of much use in early FGR, biophysical profile or maternal perception of fetal movement. Whereas these two are the cornerstone of monitoring in late FGR. How the mother feels the movement is the single most important criteria in late FGR and your biophysical profile. You will also do an umbilical artery Doppler, you will also do a CPR, but they are not going to be your cornerstone of your management. So, to put them all together, when you have a diagnosis of late FGR, do a weekly assessment. If late FGR, but the weekly assessment shows no red flags, deliver by 37 weeks, you can do induction of labor with a 50% chance of fetal distress. But if there is a drop in fetal movement kick count, or the NST is persistently non-reactive, or the BPP remains unequivocal persistently, then all those are indications to deliver, and usually by a C-section before 37 weeks. If there is a early FGR, then look at the umbilical artery. Always only follow based on umbilical artery. When it is still high resistance, forward flow is there, you can keep following an umbilical artery every week. But once it becomes AEDF, then you have to switch to DV also monitoring, and that happens 2 times a week. Now during this, if the baby reaches 32 weeks with AEDF, deliver. But during this monitoring, from AEDF, if it goes to REDF, then deliver by 30 weeks itself. But during this monitoring, if the ductus venosus becomes persistently high resistance, talk to your neonatologist. Are they okay to support? Then deliver as and when the ductus venosus becomes high resistance. And all these will be usually by a cesarean delivery. Thank you. Thank you. That was a steroid. If you have a reliable fetal medicine center, don't give it until your decision to delivery is around the corner. For example, AEDF, I call my obstetrician and say, don't panic, I am there, we will monitor this child, give the steroid when I tell you. So we call them back every 3rd day, we do the DV is good, DV is good. We are now 31 weeks, 4 days, I tell them, give the steroid, 32 plus 1 or 2 you have to deliver. And on the day of delivery, they will give Maxelf.
Maxelf, 4 hours prior you start and keep continuing till you deliver, correct?
True.
And the salt, betamethasone or dexamethasone, what?
Doesn't matter. It's a unnecessary confusion created by some quarters. Both salts will give supra-physiological dose to the fetus. And we only want 48 hours of action, that anyway is there. So the long acting doesn't need weeks and weeks. The gene expression starts within 48 hours. So both salts are okay. You can very well give betamethasone, that's available in the Indian market. If you want to give Dexa also, you can give. Doesn't matter.
Is there something like a rescue dose if you have given steroid early at 27, 28 weeks and the baby has continued okay, and now 1 month has passed and now you are planning for delivery. Suppose we gave her steroid on 5th of October and by 5th of November we have not delivered her. So should we give her a rescue dose or not?
Thank you, madam. This situation should happen only in the context of a threatened preterm labor, not in the context of a FGR. So understand these flow charts, use them in practice, get your fetal medicine team inside. For FGR, you gave and it didn't deliver, doesn't happen. In preterm, threatened preterm, we are still not yet having enough tools to correctly classify the false from the true. So we end up giving 1 dose of steroid, 1 course, and then she continues, and then she again threatens a preterm labor. We can do that, but not in FGR. But if suppose we have given based on AEDF, we panicked and gave. After AEDF in a singleton, it takes 2 weeks for the baby to reach a point to deliver. So your initial steroid may not be valid in most of them. So don't panic and give, but if you have panicked and given and if it has reached 4 weeks later, see if it is less than 34 weeks. If it's there, then maybe we can give, but it's better to be avoided.
So 1 dose is enough. That's
1 dose correctly timed, and the timing is DV.
So
DV, based on ductus, and if the ductus is normal, I have shown you the delivery limits. 32 weeks for AEDF. You are going, you have reached, day after tomorrow is 32 weeks, today you can give the steroid.
Sir, the guidelines related to giving steroids for elective cesareans, we schedule around 30, so ACOG tells to give a...
ACOG does not endorse the trial. The trial is called Aztec trial. It's only for RCOG. It's a single trial based recommendation, but comes with a lot of caution. Don't deliver just because 1 dose of steroid will help you at 37 weeks. But that's okay. That is not in this context.
Terminate the pregnancy?
Thank you, madam. Very important question. As of today, so the question is, you are following late FGR, the CPR centile keeps falling. Do we have to deliver because it's falling down? As of today, we don't do that. We follow carefully. If the centile is falling, we intensify the monitoring. We call her back every 2 days for a non-stress test. We ask the mother to be careful about the fetal movements. As of today, CPR is not a threshold to deliver. It's a diagnostic criteria.
So, sir, you will not take decision, suppose 5th centile is the value of CPR. So you will be doing monitoring still or you will be delivering?
Monitoring. 5th centile will be used as a diagnostic cutoff.
Sir, and what are the pointers towards fetal acidemia?
CPR is not. It is very poor correlation with acidemia. Acidemia, the best correlation is ductus venosus. For late FGR, there are no really good pointers. If the mother says no fetal movement, deliver.
Okay. Thank you, sir.
The jury on CPR is not yet out.
Thank you.
Thank you, sir.
I have my own lecture. I think Dr. Mani has given a very clear, what I understand, Dr. Manikandan, what I understand that you have given a very clear signal about taking decision in early FGR and late FGRs. So absent end diastolic blood flow, where you in less than 32 weeks?
We wait and do the DV. Less than 32 weeks, we just keep on monitoring the DV and NST, CTG for looking for spontaneous decelerations. The DV remains normal, no spontaneous deceleration, take to 32 weeks. 31 plus 4, give the steroid. 32 weeks you deliver after giving Maxelf.
This is very important because we are dealing with preeclampsia and growth retardation, and even 1 week or 2 days, 3 days in utero gives a better chance of survival.
Every utero is less 1 week ex utero.
Thank you.
How will the repeat steroids? You said it will boil up the fetal brain, something like that. I want to know the detail.
It will take
No problem.
1 minute.
No problem.
Right. So it's not true. All fetuses from 24 weeks onwards produce their own steroid. And simultaneous with endogenous corticosteroids of the fetus, the fetal brain produces an enzyme to break down its own steroid called 3-beta hydrogenase. Now, this enzyme of the fetal brain cannot break down the fluorinated steroids that we give externally. Why does the fetus produce an enzyme to break down its own steroid? Because the steroid has an anti-migratory activity on the cortical neurons. The neurons gets phased. They don't work well. So the fetus protects itself by creating that enzyme and destroying the steroid that it produces on its own. What we are doing is we are bypassing that enzyme and giving a steroid that cannot be broken. We can give it once because it would give survival benefit. Otherwise, we will be producing herds and herds of suboptimal performers for our next generation.
That is very important. Too much brain migration, brain formation, there might be some problem inside. So things has to be, there is a...
Pediatrician asked us to give steroid. If you are doing elective LSCs, they used to say that before 38 weeks, it is better you give steroid.
See, Sonal, we will listen to the fetal medicine specialist, not to people who are asking us. If it is evidence-based, who is asking us, we try to convince them this is not the way. And if you understand yourself that what you are doing the correct thing, evidence-based, don't worry.
So last thing was any role of aortic isthmus monitoring?
Very difficult question with no answer.
No role.
No role.
Easy answer is no role.
Banerji, sir, you're going to send me out, but one last question. Sir, GDM patient steroids.
When are you planning to deliver?
37.
Why?
3.7, 3.8 already.
Okay. In that case, if he increases the risk of stillbirth, and therefore I need to deliver before full maturation of the lungs happens, especially in a GDM, I would say you are within your clinical judgment to give steroid, but take care. Admit the lady, monitor the sugar, give the steroid. I would say yes.
Thank you, sir.
Thought-provoking. And Dr. Manikandan is with us with another growth scenario lecture later on after me. We will have, my basic aim of this FetusCon is to make you aware how to catch them early and how to have a safe delivery. In between, as a practitioner, I put a talk that is the fetal medicine is enough. मैं आप लोग को 2 केसेस, मैडम जावेद थोड़ा सा तवज्जो चाहूँगा. I discussed 2 cases before this. I will keep my talk very small. मेरे पास एक patient आती है. This patient has delivered a sickle diseased child. She is not infertile. Sickle diseased child. 2 केसेस बताता हूँ. ये हुआ है और एक पेशेंट को आप लोग जानते भी होंगे. Sickle disease child died after 2 years. She gets a pregnancy, another pregnancy. पहले वाला जो sickle disease था वो उनको मालूम ही नहीं था कि वो कैरियर है. जब उनको sickle disease हुआ तो उन्होंने अपना कैरियर स्टेटस कराया. They got the sickle cell carriers. She gets another pregnancy. She came to me for prenatal diagnosis. I did CVS and found that the baby in utero is sickle cell diseased. Answer is termination. पहला डिलीवरी सिजेरियन हुआ था. पहला सिजेरियन होके बच्चा खत्म हो गया, दूसरा एबॉर्शन कराया. She started crying. She asked me, can we have normal baby without this fuss of abortion and all? We do that. That means fetal medicine starts before conception. That is very important. Second case, spinal muscular atrophy. Baby died after 1.5 years. Both partners carriers. No infertility. Came to us, can we have a disease-free baby? Because SMA का treatment और is very costly. थैलेसीमिया की तो मैं बात ही नहीं कर रहा हूँ, थैलेसीमिया आते ही रहते हैं. एक केस और आता है, she is not having baby but recurrent abortions. She is not infertile. Can we have something you can help that we can have a normal pregnancy? मैं केस सिनेरियो बता रहा हूँ. तीसरी केस आती है, बहुत अच्छे घर की लेडी है जबलपुर की. All scanning done by gynecologist, everything. Even we miss Down syndrome. मैं बार बार ये कहता हूँ कि with this FetusCon, my Down syndrome is still they are taking birth, even though fetal medicine has gone up quite advanced. She delivered a full term after dual marker, triple marker, target scan, delivery after 7-8 days, karyotype done, trisomy 21. Caesarean section done. She is fertile. She is asking me, मतलब आप उसका दुख यदि देखोगे इन लोगों का, I felt that being doing IVF and all, is this a way that you can have a pregnancy but baby is, what is this? Can we have a continuum before pregnancy so that they can have a healthy baby? With this in mind, मैं उसका नाम थोड़ा अलग ले रहा हूँ. उसका नाम नीलम है, नीलम गजरे. उसका केस दिखा रहा हूँ. उसका पहला IVF किया हम लोगों ने. मतलब आप आयरनी देखिए. She is fertile lady. She created 12 eggs. Only 2 are mature. उसका जो blastocyst बना, that blastocyst has been examined and came Down syndrome. मतलब इतना IVF की वो झेली लड़की, पैसा खर्चा किया. सिकल सेल डिजीज का तो छोड़ ही दीजिए. बेबी इज डाउन सिंड्रोम, व्हाट इज सिकल सेल, सब रिजेक्टेड. सेकेंड, वी डिड हर सेकेंड IVF. ये अभी का ही वीडियो है. वी डिड ओवम पिकअप. सो वी डिड ओवम पिकअप and Rinku has identified the oocytes. Irony देखिए, they are identifying the oocytes and denuding. Ishani and Rinku both are working. अब irony देखिए, again she produced 15 oocytes. Fertile lady, only 2 mature जो usable हैं. 5 germinal vesicle useless and 8 degenerated useless. कितने बचे? 2. अब उसका fertilization हुआ है. We will do the pre-implantation genetic diagnosis, provided they are not Down syndrome or aneuploid. These are the oocytes which is visible in microscope. Now, she did the intracytoplasmic sperm injection. ये कोई मैं infertility practice नहीं कर रहा हूँ. ये fertile lady है. But she had a abnormal child. She had a diseased child. Is the pregnancy is enough? No. So we need to have, as a gynecologist, as a OBGY person, आपका, मेरा, सबका, मणिकंदन का, सबका, why he is practicing fetal medicine? He wants to help his client, the lady, to have a healthy baby, nothing else. उसको ये नहीं मालूम डाउन सिंड्रोम होता क्या है, SMA क्या होता है, सिकल क्या होता है. It is our responsibility that what is happening. It is your responsibility that you counsel them, help them with your wisdom. If you can't, take help with the wise man. So genetics plays a critical role throughout human reproduction. आप do away कर ही नहीं सकते. This presentation explores the continuum linking reproductive genetics to prenatal genetics, integrating clinical application for gynecologist. ये मैं हर साल ये लेक्चर लेता हूँ. What is DNA? What is this? DNA is like a thread in our body. One is coming from each parent, and this DNA of 300 billion base pairs, जैसे हिंदी में वर्णमाला होती है और अक्षर लिखते हैं, वैसे इसके भी वर्णमाला में 4 अक्षर है. दैट इज ATCG. उससे आप डिफरेंट वर्ड्स बना के उसका किताब लिखते हैं. नेचर डज इट. सो इट मेक्स 23 books, and we have 46 books in our whosoever is we are moving around. With this book, each book is called chromosome, and written in the book which is meaningful are genes. Simple. Anything written abnormally in a baby's DNA provided by the parental DNA, if abnormal, then there will be a baby with the disease. Fetal medicine is for baby in utero. So these are the mistakes nature does, but we cannot change the mistake. But we can at least identify, catch them as early as possible. No, catch them before. जो मेंटल एगनी और जो फिजिकल एगनी लेडीज फीमेल्स को होती हैं, मेल को भी होती है थोड़ा, बट रियली आई फील दैट द अबॉर्शन, सिजेरियन without having a healthy baby after cesarean section, horror. So preconception and reproductive genetics is preconception carrier counseling. यही मैरिज करके पहले यदि सिकल सेल का कैरियर देख लेते तो शायद पहले बेबी में प्रीनेटल करा लेते. उसको एक सिजेरियन हुआ, उसका एक अबॉर्शन हुआ, सिजेरियन के बाद बच्चा खत्म हो गया. Genetic counseling before conception. We all have that responsibility. Evaluation of infertility due to genetic cause. आपको in depth जाना पड़ेगा अंदर. Why it is happening so? Gamete and embryo genetic integrity. नहीं मालूम, नहीं बनता, take help. Role in assisted reproduction. हम उसको help क्या कर सकते हैं? They are not infertile. मैं इनफर्टिलिटी की प्रैक्टिस की बात नहीं कर रहा हूं. क्रोमोसोमल एंड जेनेटिक एबनॉर्मैलिटीज, स्पर्म एंड oocyte, डिफेक्ट इन सेग्रीगेशन ऑफ 46 क्रोमोसोम. कभी 22 एक तरफ चला जाता है, कभी 24 एक तरफ चला जाता है. इफ 24 मीट्स विद द 23 मेक्स 47. द एक्स्ट्रा क्रोमोसोम ट्राइसोमी 13-18 होगा तो बच्चा अंदर ही खत्म हो जाएगा, नो प्रॉब्लम. मिस्ड अबॉर्शन होगा. बट यदि 21 नंबर का एक 47 क्रोमोसोम 21 नंबर का हुआ, देन इट इज अ 60% ऑफ नॉर्मल अल्ट्रासाउंड माइट हैव डाउन सिंड्रोम डिलीवरी. उस लड़की को हुआ, जिसका हुआ उसका आप सोचो क्या गया. शी इज ए प्रोफेसर इन कॉलेज. मैं आई डोंट वांट टू रिवील, बट मोस्ट ऑफ अस वी नो देम. एंड इन मेल इनफर्टिलिटी Y क्रोमोसोम. सो in fertilization and early embryo, nature does a very smart thing. All are we born because of severe selection method. Intense selection. It is like an Olympic. It is like a hurdle race. You have to cross it, and you have to cross it fast. Then only you win. embryonic aneuploidy formation. Identify, catch them before. If patient asks, मेरे embryo में ये disease हो रहा है बार बार, catch them before. Can we do it? So genetic testing and in assisted reproduction is, I'm going into fetal medicine, but before going into fetus, it is embryonic medicine. In fertility, sterility, the recent published is embryo diagnostics. तो हो सकता मैं एक दिन embryo day भी बना दूं, because मुझे ऐसा लगता है कि why fetus, go for embryo. If you give a good embryo, chances of getting a good fetus will be good. Having a good baby will be very fine. So there are chances of pre-implantation genetic testing for Down syndrome. Why I am putting Down syndrome, not aneuploidy? Because 18, 13, 16 वाला तो missed abortion होता ही है अधिकतर. 13, 18 also goes. But 21 takes birth. So should we do aneuploidy for elder women? Offer them. मोनोजेनिक थैलेसीमिया हो गया, सिकल सेल हो गया, SMA हो गया. मैं आपको बता रहा हूँ, एक्स-लिंक्ड डूशेन मस्कुलर डिस्ट्रॉफी का लड़का बढ़िया पैदा होता है, 4 साल तक बढ़िया खुशी मनाई जाती है, फिर चलता नहीं बनता, तब तक दूसरा बच्चा हो जाता है, एक लड़का और हो गया. मैं वो बता रहा हूँ आपको, मेरे पास जो केसेस आते हैं, पता चला कि वो 8 साल तक व्हील चेयर में आ गया, चलते नहीं बन रहा, ये अच्छा बच्चा हुआ, 4 साल के बाद वो भी नहीं चल रहा. Have a horror. Embryo biopsy and next generation sequencing. That led me to put a lab, purchase laser, ask my embryologist, push them to hard to their extent. Embryo biopsy करना है. बोले एक ही embryo बना है, खराब हो जाएगा, हो जाने दो. नहीं होता. So they become accredited embryo biopsy people now. Ethical and clinical consideration. Sexing नहीं करना है, हमें डिजीज देखना है. जैसे अल्ट्रासाउंड बदनाम हुआ था, वैसे ही PGTA भी हुआ है. But it is up to me what I should do. So these are all blastocysts. इसमें 2 पार्ट है. This is one is outer part that makes the placenta, and this makes the baby. I cannot touch it, but I can take some biopsy from this, which gives an idea about this. This makes the baby. So what I should do? What my embryologists do? They make a hole in that shell and take out part of the trophoectoderm. This is embryo biopsy. Lead to a good healthy fetus. With this, I can take out the DNA of this embryo, which is going to, if survives, then make a baby. What to be done with this? Check for chromosome. Check for 46 number है कि नहीं. और यदि disease है, तो Mendelian disease को देख लो. यदि ये है, इसको हम freeze कर लेंगे. यदि ये ठीक है, then we will transfer it. So, before conception, there should be a very, जो मैं regular अब करता हूँ, that is, whosoever wants to reproduce, give them a chance. Do you want to have a carrier screening? At least, मैं सबको बोलता हूँ HPLC, जो यहाँ पर थैलेसीमिया और सिकल सेल को आप rule out तो कर दो. यदि है, don't ask them not to marry. Marry, have a prenatal. Identification of recessive and X-linked disorder, genetic counseling, and American College का guidelines है, ISHRE के guidelines हैं. Now this is there is a time from transition to now patient conceives. ये लड़की जो जिसको डाउन सिंड्रोम हुआ था वो कंसीव होकर मेरे पास आती है. Now fetal medicine starts. From the pre-implantation to intrauterine genetic assessment. What I should do? आप उसका डबल मार्कर करा लो, सब करा लो. She had an IVF twin pregnancy. पीछे पड़ गई सब कुछ ठीक है अल्ट्रासाउंड में, बोला नहीं पिछली बार भी अल्ट्रासाउंड ठीक था, आई डिलीवर्ड अ डाउन चाइल्ड। दोनों सैक का एमनियोसेंटेसिस किया, बोथ केम नॉर्मल। तब उसका दिमाग में ठीक हुआ कि एन्यूप्लॉइडी नहीं है, वी डू माइक्रो एरे ऑल्सो, वो भी ठीक है। सो देर इज फ्रॉम प्री इम्प्लांटेशन टू इंट्रायूटेराइन जेनेटिक अर्ली फीटल जेनेटिक इवैल्यूएशन through screening and diagnostic tools, integration to preconception, pre-implantation and prenatal. आप एक continuum देखो, आप उसको छोड़ ही नहीं सकते, being a gynecologist, OBGY. So what already discussed, cell-free DNA, anti-biochemistry and Mani had discussed the specificity and sensitivity not going. What I should do to give her a comfort or get a diagnostic test done as early as possible. We do Korean villus sampling. We do amniocentesis. So this is the case of that Mrs. Gajre. I did CVS. Now with this CVS under ultrasound guide, with the needle, I take out this sample from क्योंकि क्या है, यदि सिजेरियन है और आप एमनियोसेंटेसिस करें 18 वीक में और रिपोर्ट आने में एक 7-8 दिन भी लगते हैं, विद द प्रीवियस सेक्शन टर्मिनेशन इज लिटिल बिट डिफिकल्ट. As early as possible, termination will be easy. Now, I do it on, पहले मैं GA में करता था, now we do with local anesthesia. Now these are the chorionic villi which we see under microscope, and this is a mid-trimester amniocentesis. What we do for this lady who had a Down syndrome baby or any cases where high risk of trisomy and all, and whatever it comes out, the fetal DNA, we do karyotype, we do fish if it is, or QA-PCR, but I always do microarray along with that. Why? Sabkoi Down syndrome. You know, Down syndrome incidence is 1 out of 450, but submicroscopic chromosomal deletion and duplication, which are maybe as serious with Down syndrome, are 1 out of 100 in population. And if there is one soft marker, any marker, it goes to 6 out of 100. Think about it. Baby might be having no Down syndrome, but might be having DiGeorge syndrome or any submicroscopic deletion, which is as dangerous as it is. And if there is a reason to find out, go for clinical or whole exome. Problem is, who will interpret? Take help of, हमारे साथ में एक मैं भी करता हूँ, and सचिन है हमारे साथ में, he is a geneticist. We discuss and take the, so prenatal detection of monogenic disorder, targeted mutation analysis like sickle cell, thalassemia, SMA, whatever it is, inducible muscular dystrophy, all which are not chromosomal but pinpointed, known before that they are genetic disorder, find it. Karte karte, we started, by God's grace, I started a next generation sequencing lab. So this is our lab, which is with infectious genetics, like जो भी panel होते, sepsis panel, fever panel, microorganism का, within 4 hours you will get the Klebsiella है कि E. coli है, किस लिए infection है, ICU में क्यों भर्ती है. Second is, this is molecular lab. We do DNA extraction. These are all steps of DNA analysis. This is the polymerase chain reaction section. And we read all the 300 billion base pairs we read. आप नहीं रीड कर सकते, तो हम उसको छोटे छोटे बिलियंस ऑफ पीसेस में टुकड़े कर लेते हैं. हर एक टुकड़े का एक बार कोड होता है. उस बार कोड के छोटे टुकड़े को हम एक मशीन में डालते हैं कि आप उसमें ATCG का क्रम बता के पढ़ के बताइए. क्योंकि हर क्रम का जो तरीका है वो एक अक्षर बनाएगा। वो अक्षर लेटर्स ठीक लिखा है कि नहीं लिखा वो मुझे जानना है, तो मैं क्या करूँगा, नॉर्मल के साथ उसको कंपेयर करूँगा। पर मैं यदि 3 बिलियन बेस पेयर को पढ़ने चलूँ सालों लग जाएंगे। तो व्हाट आई डू, मशीन डज, वी मेक इट पीसेस, गुम ना जाए बार कोडेड, सीक्वेंस ठीक रहे बार कोडेड, उसको फिर हम, दिस इज the instrument which reads the each bar-coded fragments, and when each bar-coded fragment is read, we compare it with जो हमारे पास नॉर्मल लिखा हुआ है उसके साथ। If all million pieces are together, they read and they match with the normal reading, then it is normal. Anywhere throughout the 3 billion base pair, कहीं पर भी यदि misprint है, this machine along with bioinformatics will tell us कि इसका sickle cell की जगह पे 89 to A to G there is a substitution which makes different amino acids abnormal protein. SMN जीन में यहाँ गड़बड़ लिखा है, it creates abnormal protein. Within 24 hours. So this is the way I do practice nowadays, that couple with recurrent IVF failure, aneuploidy tested, abnormal non-invasive prenatal test, DNA analysis, amniocentesis, carrier couple for the beta thalassemia, help them to get pre-implantation genetic analysis by Mendelian disorders. I took these references from this. Thank you once again, and thanks a lot for patient listening.
Thank you, Dr. D'Pankar. It was a month ago, and they were having genetically like physical deformity in their family line, the husband's line. Like the grandfather was having CTEV, the father was not having. Again, this husband, the couple who visited me was having, and his brother was also having CTEV. So is there a they had just come to council, is there a test by which we can determine prenatally that whether this baby which they will conceive will have CTEV or not?
These are all phenotypes, what you see, because one from my father, one from my mother. Usually one misprint is not creating any problem because other normal print balances it. So it is called recessive. But if this misprint speaks and overpowers the normal print, then that is autosomal dominant. So we are worried about those misprints which are dominating the other. Most of the time, they don't recur. If we have achondroplasia or any, usually they are sporadic. Thanatophoric dysplasia, आप देखे होंगे, आप अल्ट्रासाउंड करते होंगे, एकदम छोटा, सब कुछ छोटा, baby dies. Problem happens when there is misprint which is recessive, and both the parties who are creating the baby are carrying the same misprint at same place. Because they are having a normal print, तो वो बीमार नहीं है. But they when reproduce and those misprints they combine together, तो baby with the full misprint comes. अब आप जो बोल रहे हो, this might be a autosomal dominant pattern which is not killing the person but creating a problem. तो कैसे पता करें? जो पेडिग्री बनाता, पेडिग्री में यदि ऐसा लगता है कि वो हर जनरेशन में हो रहा है, वी डू जेनेटिक एनालिसिस, जो जीन्स हैं उनका जांच कर लेते हैं, दैट इज कॉल्ड एक्सोम सीक्वेंसिंग. पूरा जीनोम करने जाएंगे तो बहुत ज़रूरत पड़ेगा तो होल जीनोम भी करेंगे, पर होल जीनोम महंगा पड़ता है. तो जो छोटा जितना काम का है, जिससे जहाँ लिखा उससे कुछ ऑर्डर मिलता है, उतने एरिया को कर लेते हैं, दैट इज कलेक्शन ऑफ एक्सॉन्स इज कॉल्ड एक्सोम सीक्वेंसिंग. तो वी डू एक्सोम सीक्वेंसिंग. उसमें यदि ऐसा कोई मिसप्रिंट मिलता है दैट इज कैरिंग इन फैमिली, आप बिल्कुल बोलो कि ऐसा हो सकता है। अब वो बोलते हैं कि हमको ये बच्चा ऐसा नहीं चाहिए, तो प्रेग्नेंट हो जाओ, मैं प्रीनेटल करके देखूंगा वेदर दिस बेबी इज विदाउट दिस मिसप्रिंट और विथ मिसप्रिंट। इफ इट इज विथ मिसप्रिंट, इट इज़ योर चॉइस, रखना कि नहीं रखना, बिकॉज ये ऐसी बीमारी नहीं है कि जिसमें बच्चा जिंदा नहीं रहता। वेरी डिफिकल्ट टू आंसर ऑल दिस। बेबी कैन सर्वाइव, वो दे आर सर्वाइविंग। तो ये जब जो डिलेमा, ये सब जो प्रॉब्लम होती है, आपको यू शुड नो इट। और आपको यदि समझ में नहीं आ रहा, टॉक टू द जेनेटिसिस्ट, आप वीडियो कॉल करवा लो, तो आप उस जगह से थोड़ा मुक्त ये हो जाओगे कि सारी जवाबदारी आपकी नहीं है, बिकॉज यू डोंट नो व्हाट इज गोइंग टू हैपन। थैंक यू वेरी मच।
Where the patient had history of Downs previously, previous baby was affected with Downs, and so you have done CVS.
उसमें मैंने अभी मैं सीवियस भी करता हूँ, पर एमनियो ज़्यादा करता हूँ।
See, so my concern is कि if she had Down, we can do NIPT first, and if it is positive.
I ask money also.
So no, then out of CVS and amnio, because in CVS we are collecting the placental tissue.
Exactly.
So I think invasive amniocentesis is better, or we can still do CVS.
Your question is so pertinent. इसी बात पे इंटरनेशनल सोसाइटी ऑफ प्रीनेटल डायग्नोसिस में NIPT डाउन सिंड्रोम आया, शुड वी डू कोरियन बायोप्सी और शुड वी डू एमनियोसेंटेसिस? एमनियोसेंटेसिस।
Okay.
Why? Because it is a chorionic tissue, there might be a discordance.
Yes.
पर जो concordance मिला पूरे उसमें, for Down syndrome, more concordant. Other, be careful.
Okay.
यदि आपको 13 मिलता है, 18 मिलता है, confirm it by amniocentesis, because it might be a confined placental mosaicism.
Okay.
तो जहाँ तक हो सके जेनेटिक डिसऑर्डर के लिए, फॉर जेनेटिक डिसऑर्डर, मेंडेलियन डिसऑर्डर, CVS इज ओके, बट फॉर डाउन सिंड्रोम एंड एन्यूप्लॉइडी आई नीड fetal DNA.
Fetal DNA.
So I prefer amniocentesis, and I am pro invasive amniocentesis person.
No, yes. Thank you.
Can I answer the previous one?
Yes.
Just to answer that question where the father's brother, the grandfather, but not the father, that pedigree is autosomal dominant with incomplete penetrance. This fetus's father might still be carrying the gene, only he may not be manifesting it. That's very typical of autosomal dominant. But the question is, can I do a genetic study to identify CTEV? If you enter the genetics of CTV, it's very complex and very low yield for a condition that is completely correctable. So rather, if I am going to give the counseling, I would say there is a chance, and we will pick it up in the ultrasound anyway, but why do you bother? You have healthy parents, grandparents, even 2-3 generations before. Current treatment of CTV is so good that they can go for military recruitment also. So that should be the counseling for that. For CTV.
I counseled the same to the patient, but her answer was that she doesn't need a baby who should have this deformity. Yeah. So is there a test which can diagnose it before?
Like Dr.
So
D'Pankar
yes, I will send them to sir.
Yeah,
definitely.
but the yield may not be good after, so that also we should highlight before. Unlike sickle cell and thalassemia and Duchenne, if you start investigating CTEV for the gene defect, most of the time you will end up not getting it. And you may highlight some uncertain significance. Yeah, correct.
Thank you.